All right, y'all ready? Yep. The official timekeeper says it's 1 o'clock, so it's time to go. So some of you I know, some of you I don't. My name is Nathan Hale. I'm faculty in the Department of Health Services Management and Policy. I think I'll be with you for the next 2 weeks. Is that correct? Yeah, this week and next week. So hopefully you're learning a lot. You got the semester off to a good start, and this won't be too unbearable for you. But today we're going to be talking about specifically healthcare delivery in the U.S. and focusing heavily on how it's financed. We're going to talk a lot about insurance and how that works, and hopefully you'll have a better understanding for that as you move forward. And I kind of teach this in various forms and different capacities, and I actually think that this set of material is not only beneficial from an academic perspective, it's actually beneficial as a human being perspective, because when you get out, you're going to have to select insurance plans, you're going to get a bunch of paperwork, and you're going to look at it and think, oh my gosh, what in the world am I supposed to pick here? So this actually may help you sort through those decisions. So, fair enough? I tried to put a game in there to break it up because it's very lecture heavy, so I apologize in advance. So this is what you're going to learn. You're going to learn stuff today. I already kind of told you what that stuff is, but just for the sake of formality, we're going to describe the role of the healthcare delivery organizations. We're going to identify key issues with the financing of the healthcare services. You are going to be able to articulate access and cost challenges facing the U.S. healthcare system, and you will be able to differentiate among the availability, acceptability, and accessibility of healthcare across diverse populations. So those are your formal learning objectives that we will be addressing today. So the way we're going to break this down, we're going to spend the first part of the class talking about healthcare spending and focusing heavily in on cost, because that's kind of the elephant in the room as it relates to the U.S. healthcare system. We'll talk a lot about insurance, particularly private insurance and how it works. So then we start talking about the ACA and the insurance market reforms, that will make a little bit more sense. So we'll take a little break. You guys can kind of collect your thoughts, and then we'll come back and talk about public financing, which is effectively Medicare, Medicaid, and public forms of insurance. And we'll talk a little bit about access and what insurance equates to as it relates to access. And that'll get us where we need to be heading into next week, where we'll talk really specifically about the Affordable Care Act, what's in it, what's not, what's real, what's hot, all that kind of stuff. So that's where we're headed for the next 2 weeks. So, how many of y'all have seen this before? Besides Bethany, she's in my undergraduate class. How many of y'all have seen this? For real? That many of you? Wow, we're doing a great job. So, let me back up and say, if I had to ask you, where do you think the U.S. healthcare system ranks among other industrialized countries, what would you say? Huh? Really? Based off what criteria? Why would you say that?
The cost is high.
Cost is an issue, right? What else?
Accessibility is difficult for some people.
Accessibility or accessing healthcare services is difficult, yeah. What makes it difficult? Put you on the spot.
Insurance.
Yeah, insurance, cost, yeah. What else? Why else would you say it's not the best?
Outcomes.
Yeah, outcomes. We'll talk about that in a minute. That's a big one.
Cost.
Sorry, I heard something.
Cost.
Yeah, cost is definitely one of them. Right, so I'm a little bit surprised. Typically when I ask students that, they're like, no, the U.S. has the best healthcare system in the world. And then, and then I show them this to say, no, that's, verifiably false. So this particular study is from a study from the Commonwealth Fund, which is a reputable nonprofit organization. They look at healthcare systems across all industrialized nations, and they rank them based off of the quality of care, so like how effective it is, how safe it is, how coordinated it is. They rate them off of access, so like do you have cost-related issues in accessing health care, the timeliness of care, right? So it's one thing to have access to care, but if it takes you months and months and months to actually get it, that can be problematic. They rate you based off of the efficiency, the equity, and actually how healthy you are. And they look at that in the context of how much money you spend on health care. So I'm going to skip to the chase here, and this far right-hand column is the U.S. healthcare system, right? So what you need to know is that when you see light blue and white, that's bad, particularly white. That means you're in the bottom two, right? So you can see here 1, 2, 3, 4. At least 4 categories the U.S. is like in the bottom 2. Actually, we ranked dead last, number 11, based off of this metric of criteria. So that's not good. Clearly, when we rank us up against other countries and you look at access and outcomes and cost, we tend to not do as well. A couple issues here. One is that we rank 11th when it comes to healthy lives, which that was mentioned earlier. Like we typically have poor health outcomes. We don't live as long as other countries, and the years that we do live tend to be compressed with a lot of chronic conditions and not necessarily high-functioning years. This big one down here, 8508, per capita health spending. What is that? What is per capita health spending?
We spend $8,500 on each person.
Yeah, so on average in the U.S., for every citizen that's here, we spend about $8,000, $9,000 per person per year. So the next closest country, I think, is Switzerland, maybe, Norway, right in there. So they're like 5,000, 6,000. So we spend a lot more money per capita than any other healthcare system in the world, and we still kind of rank dead last, and we still don't really have a lot of healthy folks to show for it, right? So that's kind of a problem, right? If you're a public health person, that should be a concern for you. If you're a policymaker, that should be a concern. Now, I'll point out, because we always want to be transparent when we're looking at data. France over here ranks number 9, so they're only like 2 ahead of the U.S., but look at their healthy lives ranking. They're number 1, right? So clearly that's something we need to pay attention to. What about the U.K. over here? Where do they rank? Yeah, like by objective metrics, their healthcare system performs pretty well. When you look at healthy lives, they're really not far behind us. So the point being here is that the U.S. clearly kind of lags behind when it relates to other countries based off of the criteria used in this study. However, there are countries that don't necessarily have great healthcare systems that still have better outcomes. And there are countries that have really good health systems objectively that still end up with poor health outcomes. So clearly there are a lot more factors at play to producing health and well-being at the population level besides healthcare systems. Now, with that said, this is a split class on the healthcare system, so that's what we want to talk about. Certainly a contributing factor. So hopefully this is a review for most of you, and you've probably heard this in different courses and various lectures. But if you look at per capita health spending, and this is just reiterating what we've already stated, but sometimes it helps to see it longitudinally and see it proportionally. Clearly, when it comes to per capita spending, we spend far more than the next closest country, which is Switzerland, right? So that's a problem. If you look at the percent of the GDP, so what is the GDP? Okay, what is that? I know you know what it means. What is it like in hillbilly English, which is what I speak? What is the GDP? It's like the total economy, right? So if you took the whole economy of a country, like all the money that's spent on goods and services and education and whatever, if you look at that, if you think about it as a big piece of pie, which is probably not good exactly for lunch today, the more that healthcare takes up of that overall pie, what does that mean for everybody else that's in the same pie?
Less pie.
Yeah, there's less pie for everybody else to eat, right? So the more that the U.S. healthcare system, the more that we spend on healthcare, the less money we have to spend for education, for national defense, for whatever it may be, right? So the fact that it's eating up such a huge chunk of the economy, in and of itself, should be a little bit of a red flag. But let me ask you this, right? So is that inherently bad? Is it bad that you spend 18, 19% of your GDP on healthcare? Right, so the U.S., by objective metric, has, one of the largest economies in the world, probably the largest economy in the world, if I'm not mistaken. So if you have a lot more money than everybody else, why shouldn't you spend it on healthcare? Anybody want to answer that?
You might be able to spend more on public health and then reduce spending on healthcare.
Wow, imagine that. That's a novel concept coming from the public health. Yeah. Well, yeah. So I mean, the point is that it's not so much that we spend a lot of money on healthcare; it's that we spend a lot of money on healthcare and basically have not much to show for it. Right? You're average, if not below average, when it relates to health outcomes. Yet you're spending so much more money than everyone else. And it's not so much that we're spending a lot of money on it; it's the trajectory of that spending over time that is concerning. So when you look at it as a percent of GDP, you can see that, from this goes back to 1960 and projects out through 2030, that there's no end in sight to rising healthcare costs, right? Like there's just absolutely no end. It gets more expensive. We keep spending a lot more money. It's not a good situation all the way around. So by 2030, you're talking about 1 out of every $4 circulating in the U.S. economy going directly to healthcare-related expenditures. Right, that's going to be a problem. What happened around here that kind of helped move this thing going this way? What happened in the 60s and 70s that...
Medicare, Medicaid.
Yeah, Medicare, Medicaid. We're going to talk about that in a little bit, right? So, all right. So healthcare spending in and of itself was one thing, but here's another interesting piece of information here. So we kind of divide this out into per capita health spending and whatever. But did you know that 1% of the population, think about that, 1% of the population accounts for 21% of all healthcare spending? Okay, so the top 5% of people who live in the U.S. account for half of all healthcare spending. I want you to let that sink in for a minute and think about what that means. If I had Jeopardy music, I would play it. What does that mean? 5% of the population accounts for 50% of healthcare spending.
We're spending more money on the people who are wealthier and have more access to health care.
I don't want to sugarcoat it. That's not what I was looking for.
Oh, sorry, sorry.
But I appreciate the effort. Leslie.
It's that the sickest people end up taking up most of our expenses in healthcare.
Yeah, we have some really, really sick people, and those really, really sick people consume a heck of a lot of healthcare resources, right? I mean, that's effectively what I was looking for with that response, right? So it's not even that, if you just kind of look at the population level, it's not that everybody's spending a ridiculous amount of money on healthcare services. It's just that there are a handful, 5% of the population, that are really sick, and they consume a lot of resources. Now, who do you think that is? Like, let's just spitball it for a minute. Who do you think, is going to consume a lot of, who's in that 5%?
Elderly and disabled.
Elderly, right? So certainly as you get older and you have a lot of end-of-life issues, I think I read somewhere where, the vast majority of, if you took the individual healthcare spending of a person over their lifetime, 95% of it occurs in the last 6 months of life, right? So we tend to take a lot of heroic measures to keep people alive, which, when you're in your 20s doesn't sound like a good idea, but when that's you laying there and you're looking at your family, maybe it does sound like a good idea. Who else is in that? I heard disabled, right? So people who have disabilities, genetic conditions, chronic conditions, there are lots of reasons why folks would consume a lot of resources, right? So we're just thinking out loud, but those are all correct. So let's have a moment of self-reflection. Why are rising healthcare costs a problem? I want you to jot this down, right? Just so you don't have to stare at me the whole time. Jot this down. Why are rising healthcare costs a problem for the government, for employers, and for you as an individual? I really just need to take a drink, so I need you to write it down. I'm going to give you 30 seconds. This shouldn't be too hard. We got a lot of stuff to get through, so we don't want to spend too much time. I just want you to think about it. So, why are rising healthcare costs a problem for the government?
Let's just spend on the pie.
Less to spend on the pie. Why else is it a problem for the government? Is government becoming more responsible for healthcare delivery or less responsible? Raise your hand if you say more. Raise your hand if you say less. Okay, not raising your hand is not an option. Do you think the government is becoming more responsible for paying for health care? Yes or no? Raise your hand. Right. Are they becoming less responsible? Raise your hand. Right. They're going to be more responsible. Like, I'll show you that in a minute. Right. The proportion of health care spending that is absorbed by government sources of funding is increasing. Right. So the government, you know, as healthcare costs rise, they're bearing a significant part of that rising burden. Employers. Why are rising healthcare costs a problem for employers?
It's expensive to pay for insurance, and like if you provide services for your employees, like some companies will like pay for your heart surgery or whatever. It's like it's becoming more expensive to do that.
Yeah, so there's a financial cost on employers. Anybody else want to weigh in on that one?
You have to cut the pay you give your employees in order to pay for healthcare.
Yeah. How much money do you think your employer's going to lose off paying for your insurance before they start cutting into your paycheck to offset it? I mean, the answer is not very much, right? Like, so just be warned. And I'll show you some interesting data here in a little bit that shows that it's actually pretty proportional. Both employers. So what about individuals? Why are healthcare costs increasing problematic for you as an individual consumer of healthcare in this country? Access, right? Why? What about access? Why is it an issue?
Well, if you don't have an insurance, then you can really, it's affordability as well. Like people can afford it.
Yeah.
They can afford insurance, so they can really get preventive care.
Yeah, so as the cost goes up, what happens to the cost of insurance? It goes up. When the cost of insurance goes up, what happens? Yeah, it's really hard to afford, right? Is insurance important?
Yes.
You guys ever seen the movie Willy Wonka and the Chocolate Factory?
Yes.
Right, insurance is your golden ticket, right? Like insurance is what gets you into the chocolate factory. In this case, the healthcare system, right? So again, like all those are right. So again, that was a very high level overview of some bigger concepts, but this whole issue of cost and the ripple effect that it has throughout the entire healthcare system is absolutely critical for us to make sure that we understand moving forward. So let's talk about, it's one thing to talk about spending 20% of your GDP on healthcare, but we really have to kind of get into the financing of all this, right? Because some of that money's coming from private sources, some of that money's coming from you, some of it's coming from the government. There are lots of different ways in which this is getting financed. So we need to take a closer look at who pays for what. So I was supposed to talk about how the U.S. healthcare system is structured today, like that was part of it. But I can basically talk about that in this one slide, because if you want to know how the U.S. healthcare system is structured, all you have to do is follow the money, right? So where is the most money spent in the U.S. healthcare system? Yeah, hospital care accounts for about a third of all healthcare spending. Physician services is about another 15%. So together with the cost of clinical services, that's a little bit more than half. So about half of all the money that's tied up is in direct patient care with hospitals and physicians, right? So that's typically what we associate it with. Prescription drugs, right? About 10% of all healthcare spending is on prescription drugs. Do you think that's going up or down? Yep. Healthcare spending on prescription drugs, if I'm not mistaken, is actually the largest proportional increase in healthcare spending over the past several years. If you think about this as a continuum, right? So, we got the bulk of it being paid for over here. Where is it? Governmental public health activities. So, if you think about a system, right, like governmental public health, those are services that are population-based, open to everyone. Everyone benefits from those. we spend about 2.5% of all of our money on the most broad-based public health. Somebody raise their hand. What?
Does this include private spending or just public spending?
This is all spending.
All spending.
So if you think about this as a continuum, not very much is spent on the front end, right? Like on the primary prevention side, which means that you spend a lot of money over here on the treatment side, and that kind of includes prescription drugs. Then you get over here into like nursing care facilities, home health, right? So if you think about it as a continuum, you kind of go from this most broad-based public health to clinical systems, hospitals and providers, and then on to more specialized care like nursing homes, rehabilitation facilities, and so on. What do you think the second, let me ask it correctly here. Of these categories, which one do you think is growing at the fastest rate besides prescription drugs? Anybody else want to repudiate that? Long-term health, nursing home care, home health, things like that? Yeah, I wouldn't repudiate it because it's correct, but I just want to give them an opportunity. So why are we seeing an increase in long-term care spending?
We're getting old.
Huh?
We're aging.
Who's getting old?
The baby boomers.
Yeah,
The
our parents.
greatest generation.
Baby boomers. You guys, I want to be culturally sensitive here. You know why they're called the baby boomers?
Because they're taking
They're
care of
lonely.
Listen, I turned 40 this year. I know you guys were a lot younger. You know why they call them the baby boomers, right? Like that's like my parents' generation.
His parents' generation.
You know why they call them the baby boomers? You guys like too embarrassed to say it? Right, like everybody was happy when the war was over. Like when everybody's happy, you end up with a lot of babies. And there were a lot of babies born after World War II, and like all those babies that have been working for all these years are hitting retirement now, which means they're hitting what? Come on, I'm setting you up for stuff we're going to talk about later. What are they hitting now? They're hitting Medicare. What does that mean for you?
So they retire.
Taxes.
Yeah, you got it. Yeah. Who do you think pays for Medicare? Where do you think that money comes from?
us.
It comes from you. You're paying for your parents' health care right now. You just don't even know it. All right. So anyway, we got some detailed information on that coming up, but I just wanted to prep you a little bit. So financing is just the mechanism to pay for health care, right? So when we start talking about the money, when you look at that, when you back up and look at this, somebody's paying for this, right? There's some uncompensated care, and that's a big deal, but for the most part, this is being paid for in some way, shape, form, or fashion. That can come from private health insurance, right? Whether that's bought through the individual market or whether that's through your employer. It can come from public insurance sources like Medicare, Medicaid, and like various other ones. It can come from self-pay or uncompensated care, charity care, like all those categories contribute to this really complex and unique form of financing in the U.S. healthcare system. So let me ask you this. Do you think the U.S. healthcare system was planned?
No.
Was it planned to turn out the way that it did? No, it wasn't planned, right? So I'll give you a little bit of, we have a lot of material to cover, so I don't want to get into too much detail here. But it's baffling that if you have one of the largest, most productive economies in the world, that you end up with a healthcare system that is so complex, fragmented, multiple payers, many plans, many programs, many payment models. It's just buckshot all over the place when it comes to payment and financing. But it's actually some interesting history here, and I'm a sucker for history, so I'll just tell you. What ended up happening was that, we talked about the baby boomers in World War II. So what ended up happening was that, when the war occurred and World War II was going on, and there was kind of a post-boom economy associated with the war, so it kind of got the U.S. economy, going back on track. But during the war, there were things like wage freezes and things that were happening at the national level to control inflation. So health insurance became an incentive that could be offered to employees in place of money, right? So they froze wages at the national level, so they couldn't give you a raise for doing more work. So instead of that, to attract better workers, companies started offering benefits, which included health insurance. So that really kind of linked health insurance to employment in the U.S., right, in a way that you don't see in most other countries. But interestingly, what happened was that in other European countries where most of the fighting and the infrastructure was, demolished, they were trying to rebuild their countries. They had no choice but to provide health care for their citizens if they wanted to rebuild their country, whereas in the U.S., everybody was working, the economy was booming. It's like there's no reason for the government to do this. Private industry can take care of it. And it's just been that way ever since, right? But what's happened, there was one point where 70% of all people in the U.S. had insurance through their employer. Do you think that's more or less now?
Less.
Significantly less, right? And as that has lessened, who's had to pick up the burden? The federal government, right? So you kind of see what's happening here. So it started off being a very private-centric, employer-based, which you could kind of get away with because the economy was booming and people were working. As that has shifted over time and manufacturing moves out in particular and things like that occur, a lot of that burden is shifted to the government. So over time, there's been more of a balance, and you've got, basically half private, 40% government. And that's where you see a lot of the friction between, the private delivery of healthcare versus public delivery and so on. So that's just an interesting, bit of history to kind of help you understand why we ended up with this weird, complex, multifaceted system. But if you look at financing, overwhelmingly, about half of all spending is private, meaning that, private insurance plans through your employer, things like that. Second behind private is Medicare, right? And clearly that's getting more and more of an issue as baby boomers retire. If you kind of combine Medicare, Medicaid at the federal and state level, that's going to be about 43% of all healthcare spending. So about half private, 43%, public, whether it's Medicare or Medicaid, and you kind of got this other out-of-pocket stuff hanging in there. So this is just a reiteration. I've already kind of hit all this, but just for the sake of making sure that we're on the same page. So we have a private healthcare system. So like if you had to put a label on it, you would label it private. But 43% of it is funded through public sources, right? So there's been a shift more towards public sources, particularly since 1965, in which what occurred? Yeah, Medicare, Medicaid. I'm just curious what it looks like from back here. I'm not trying to creep on y'all. So anyway, health insurance is definitely one of the key factors in accessing health care. It's the golden ticket that gets you into the chocolate factory. It's what allows most of us to seek and receive services. But it also really complicates market interactions, right? So I said that the U.S. has a private market-based healthcare system. What do you know about a market? Right, so let's talk health economics here. What is a market? Looking for two words here.
Buying and selling.
Buying and selling. What's the other two words for buying and selling? Supply and demand, right? So like in a purely theoretical economic model, you have people who are supplying healthcare services and you have people who are demanding healthcare services, right? The idea is that you supply services in proportion to demand, and there has to be competition for it to be successful, and people have to be playing on the same playing field, right? So if you want to go buy a new computer, you want to go buy a new flat screen TV, what would you do?
Research it.
Well, yeah. How would you do it? What would you do?
Prices.
Go online and look where.
Stuffs.
I'd probably go to Best Buy first. Then I would look at Target. And I would look at the prices for the flat screen TV that I wanted, the computer I wanted, whatever. And I can make a reasonable decision, right? Like I want a 47-inch HD, whatever. Can you do that in healthcare?
No.
Do people think that you can do that in healthcare? Yes. Yeah, and in my opinion, they're sadly mistaken, but that's fine. That's my opinion. So in a true market-based system, you have suppliers and providers. You have supply and demand, or consumers of healthcare and suppliers of healthcare. Back up. In a true market-based reaction, put healthcare aside, you have information on flat screen TVs, and you can make an informed decision about whether or not you want to spend the money and what type you want. How is that different when it relates to healthcare? just looking for a couple of key things here. We don't spend a lot of time on it. How is it different?
It's fixed. You basically just have to pay whatever is required of you. You don't question much.
Yeah, you have
You
to
don't
pay
have
whatever
choices.
this job. I mean, you cannot pay and then run the risk of getting sued and going to jail. How else is it different?
Providers have option to accept or deny on top of insurance.
Yeah, providers can choose if they want to see you or not based off your insurance.
People often don't know the terms of the insurance that they're signing up for, what conditions are
Yeah,
covered.
insurance is complex. We'll talk about that in a minute. What else? Let's just say you didn't have insurance and you were trying to figure out, you know, I did too many burpees yesterday and my shoulders hurt and I want to go see a ortho. Can you just like look up the cost of what it's going to cost you to go to
No,
the orthopedist? Could you call the office and figure it out?
no.
Maybe, I don't know. Right, let me ask you this. It's probably not a good example. I was gonna say if you're walking across the street and you get hit by a car, but that's not. Let's say this, let's just say you're walking down the front stairs over here and you're bored to tears from Dr. Hell's lecture and you trip and blow out your knee. What's gonna happen?
Call mom.
Call the insurance.
Your friend who's walking beside you and hopefully didn't trip you, is probably going to call who? They're going to call 911, call the ambulance. The ambulance is going to come here and get you. Where's the ambulance going to do with you? They're going to take you to the hospital. Which hospital are they going to take you
The
to?
most expensive one.
The closest one.
They'll take you to JCNC.
Yeah.
Not Franklin ones.
So, if you're walking down the street and blow out your knee, let's just assume for the sake of argument that you could call up and figure out how much it's going to cost. You got hit by a car, or if you blow out your knee, are you really going to take the time
You'll be
to do some research on which emergency room is expensive? So, what is that a market interaction?
No.
I mean, I don't think it is. I don't think it meets the definition, right? So, but that's an issue. That's what I'm saying. Like, you know, you have people who, and I don't want to disparage anyone's point of view, but there are folks who lean more towards a private market-based solution to fixing these problems. Then there are others who argue that healthcare is nothing like a market, right? Like, you know, your health and your well-being is not a commodity. It's not something that you buy, sell, and trade. So let me ask you this. When you go to the doctor, can anybody just be a doctor?
What?
Can you just go open up a clinic and be a doctor? No, right? Like you have to go to school and it takes a long time, right? So in a true market interaction, you have many buyers and sellers. You have to be able to get in and out of the market, and if somebody's not doing a good job, then you should be able to start your own company that rivals them to drive down costs and whatever. So no, you can't just go be a provider. You can't just go be a nurse. You can't just go be a healthcare provider. Let me ask you this question. You go to the doctor and you don't feel well, and they say, okay, we're going to run this lab on you, and we get the results back, and it showed this finding, and we think that you need this medication, which costs this much money, and your insurance may or may not cover it. There's going to be a copay involved. I about walked into the TV. How many of you all would question your doctor's advice? Couple?
Well, I've actually had the experience of doctors altering their recommendations for care based on cost.
Bingo. If I had like a piece of chocolate, I would give it to you. Actually, I wouldn't, because you shouldn't be eating chocolate. It's not good for you. Unless it's dark chocolate, then it is. I said dark chocolate. I said dark. Yeah, that's the issue, right? So to be a true market interaction, right, you have to be on the same level playing field where you both have the same information. Do you know as much about treatment as your doctor? Like, I'm sorry, Google is not a doctor, right? You know, I actually do question my doctor a lot. Like they hate to see me coming in a lot of ways. It's just a personality flaw. You know, it took me 40 years to convince myself that I couldn't beat genetics, and I did just take the high cholesterol medicine, even though I've had doctors throughout my entire life be like, you know, it wasn't until I reconciled myself to the fact that my mom gave me a defective gene that doesn't allow me to push LDL from my liver that there's nothing I can do about it, no matter how many burpees I do or whatever. Anyway, but for the most part, we yield our decision making to who? To the doctor, right? So we are trusting that the doctor is going to act in our best interest and make decisions based off of what's best for us and not what, how much they're going to get paid, right? So that's an issue. So we have to think about when we're talking about, is it a private system or, you know, do we want more government involvement? Like, those are things we need to consider. And a lot of folks feel like healthcare just doesn't fit a traditional market. So the basic principles of market, supply, demand, competition, they might work a little bit, but for the most part they don't. But that's kind of the friction that you kind of pick up on in the U.S. healthcare system. So there are different types of health insurance, right? So you can have group insurance, which is what?
Like all of the ETSU is all of the employees of East Tennessee State University would be on the same insurance plan. So the university pays one set price for everybody to have insurance.
Yeah, so your employer-sponsored health insurance would be another way to think about it, right? So it's not just ETSU, it's the whole state of Tennessee. So we get insurance through the state of Tennessee, and everybody that works for the state of Tennessee is all in the same great big group, and we all get charged the same rate within, depending on what kind of plan you choose. That's group insurance. Individual private insurance, what is that? If you don't have a group, like if you don't have employer-sponsored health insurance, you have to go do what if you want insurance? You have to go buy it in the private market, right? So just so you know, group insurance, does the individual pay all of their insurance costs or is part of it?
Should depend.
Employer pays.
Typically, you pay part. If it's a good insurance plan, you only pay about 20% of your premium and your employer pays the rest. If you go buy it in the private insurance market, the individual private market, do you pay all of it or a part of it? You pay every skipping penny of it, right? Like, you're totally responsible for that, right? So that's important. We're going to talk about how private insurance markets work here in a minute, so I don't want to get too far ahead of myself. Self-insurance. So a lot of big companies will self-insure. They'll set aside money from their revenues and their budgets and just pay for health insurance on behalf of their employees, and most of them will contract out with a third-party, vendor to like manage the claims, right? So University of South Carolina is where I was before I came to ETSU. University of South Carolina did that. They used to be under the state system. They self-insured. We didn't know the difference. Like, I didn't even know until like 2 or 3 years later. So, same plan, same concept. It's just that they set aside their own money as opposed to, I'm sure there's a financial advantage to it or they wouldn't have done it. Managed care, a little bit different of a concept where you have a managed care company who contracts with providers to provide services for a panel or a group. Managed care got a bad rap in the 80s and 90s, but for the most part, managed care is really the standard now. Like, everybody's in a managed care plan. So even group insurance, right? So I'm in a managed care plan. I'm in a PPO, to per provider. That's a managed care plan within group insurance. So managed care obviously has an incentive to control costs. We're not going to talk about that today, but just know that that's what managed care does. High deductible health plans, what's that? This is popular in your age demographic.
The amount of out-of-pocket payment is going to be higher if you're paying a lower premium.
Yeah, so you can get a really low premium, like $50, $100 a month. Your deductible is like $5,000, $10,000, something like that. These are typically coupled. Those are another word for those would be catastrophic plans, right? So you're really just trying to protect yourself in case you get hit by a car, right? And these are typically coupled with a health savings plan where you can put some of your own money in an account, and then as you have things come up, then you can just kind of pay for basic health care out of that account, but you're kind of covered granted, you're gonna be coming out of pocket, I mean, it's your money, I mean, you had to put it aside. Anyway, those are a little bit complicated. But those are pretty popular, right? And like, these are picked as a solution to the issue a lot of times because they make you more aware of how much money or how much health care you're consuming as an individual, right? Like, if you're having to take money out of your account to pay the doctor every time you go to the doctor, how often are you gonna go to the doctor? Only when you really, really need to go to the doctor, right? And that's kind of the point. So, but there's some issues here, right, that we need to talk through, and these are important. Moral hazard. This is a concept that is important for insurance. So, the last time you went to the doctor, if you have insurance, and if you don't have to volunteer if you don't want to, if nobody does, I will. How much did you pay last time you went to the doctor? You guys are young and healthy. You don't go to the doctor, do you?
I had a couple thousand last summer.
Wow.
That
Like, even with insurance? Is that your own plan, or are you still on your parents?
still on my parents.
Okay.
So they paid a couple thousand.
Right. Anybody else? I don't know. Like last time I went to the doctor, I had to pay $25. Can't remember why I went. Yeah, $25. Like when my kids go to the doctor, how much do I have to pay? Usually not very much because they're well visits, which are under the ACA have to be covered at no cost. So that's a perk. How much did it cost me last time? When was the last time I went to the doctor? It's within the year. Anyway, it doesn't matter. The point is, if you have insurance, what do you do when you're sick? Or when you're marginally sick? You use it. You go to the doctor, right? Like, that's the point of having insurance. Like, I'm paying money to have insurance. So if I'm sick, if I've got a sniffle, or if I even feel like I want to go to the doctor, I'm going to go to the doctor whether or not I need to, right? So the idea is that, we may have a premium that we pay every month, right? So that's kind of how we feel entitled to go to the doctor whenever we want to. But when you go to the doctor and you get your bill, how many of you ever gotten a bill from your doctor and you look at it and you're like, holy, what is that? It's like a couple $1,000, $16,000, and then you're like freaking out for a minute. And then you look at the bottom and it's like, you're responsible for $150.
Wow.
Right? Well, the point being is that typically going to the doctor, especially if it's like for any type of procedure, is expensive. Right? So like my niece had to spend 2 nights in the hospital a couple of years ago and it was $16,000. Right? So this is not, my dad recently had some heart issues and he was in the hospital for a week, and then he had to have a lot of, invasive, like, heart procedures done and stuff like that. And I can't remember what his bill was. It was, like, over $60,000, like, something ridiculous like that, right? But when you're sick, do you think about that?
No.
I mean, it may be a thought in your mind, but, like, you're not so worried about it. You know you're going to have to pay something, but you're not going to have to pay $60,000, right? What is that? That's moral hazard, right? Like, you're shielded from the true cost of what it takes to provide that service. You have to pay $100, or you may have to pay $50 or a copay, but you don't have to pay the full proportion of that bill, right? So what does that mean? That means that when you're sick, you're going to use your insurance, right? That's moral hazard, right? So what's the problem with this? We all end up using a lot more health care than we probably should or really need to. Like, that's kind of the point here. And what happens whenever we use that? Right? It goes back to that great big pie, right? That's kind of the problem there. So that's one side. Like on the demand side of insurance, that's an issue, right? Because we tend to overuse because we have insurance. What's the reciprocal of that? What about the supply side? What about providers? Are they influenced by the fact that you have insurance or not? You think so? Right? Now, I'm going to give them the benefit of the doubt and say no. Right? Like most healthcare providers, most doctors, they just want to take care of their patients. They mean well. like I don't want to leave, I'm being facetious for the sake of entertainment, but providers are genuinely trying to do a good job and do what's right for people. However, there are financial realities to opening a medical practice. It's an entrepreneurial venture. That's the flip side of having a private-based healthcare system. Like, you can make a lot of money in healthcare in the U.S. So new technologies, right? So there's a lot of new technology. Whenever you introduce new technology into the healthcare system, do you think they pay you more or less for that technology? More, right? Somebody's going to have to make their money back for putting that technology out there. Is it always more effective or not?
Well, yeah,
Toss up. Sometimes it is, sometimes it's not. So, for example, whenever you do open heart surgery, several years ago, you know how they do open heart surgery? Yeah, they basically take a saw and cut your sternum and rip your chest open and like do surgery on your heart and then close it back and it heals, and they sew it back and it heals. So clearly, like that's kind of rough on your body, right? So what do you think entrepreneurs do? I mean, they come up with new procedures, new technologies, new ways to do it. So now they can do open heart surgery or do things differently where they don't have to crack your chest open and do all these things. Do you think that it's more effective or less effective or the same? How many of you think that it's more effective? Not raising your hand. How many of you think it's less effective? How many of you think it's about the same? Right, just a pro tip here, if you're ever in doubt, go with the middle, right? So, I mean, that's basically it. Like the outcomes, objectively measured outcomes on patients show that there's not really a benefit, right? Like there are no reduced complications is about the same. But who do you think gets paid more? The crack open your chest ones or the fancy new procedure ones? Yeah, so anyway, so providers, in a lot of ways, because you have insurance, providers are just providing care, right? Like in most cases, I would argue they probably don't know exactly how much it costs. That's more of a financial business side model. They're just providing the best care that they think is reasonable for you at whatever point in time in which you're seeking those services. But there are more and more expensive procedures, so this is something called supplier-induced demand or provider-induced demand. So because we defer our decision-making over to providers, do they have a financial interest in doing more stuff to you or less stuff to you? More. Is it always needed? Right? Yeah.
Excuse me. We need to provide new technology, for instance. Are we saying it's always more? I mean, it's more expensive. I get that point. But are we saying that it always doesn't give more benefits?
Exactly.
Is it always so?
Not always. Sometimes it does.
Okay.
Sometimes it doesn't.
So it goes both ways.
It can go either way. Exactly. So the point being is that in a lot of cases, particularly, and we're not going to get so much into how, the difference in fee-for-service and capitated rates and things like that. But the U.S. healthcare system has historically been a fee-for-service based system, which means what? What does fee-for-service mean?
For the service.
It's exactly what it sounds like, right? Like you don't have to be super smart to figure that one out, right? Like if you go to the physician, you're going to get a bill for the counseling, you're going to get a bill for the labs, they're going to bill for whatever supplies they gave you. Everything that happens in that encounter gets a separate line item and a separate bill attached to it, right? That's fee-for-service. So what's the incentive?
More services.
More stuff, right? There's been a fundamental shift in the way that healthcare is paid for now, more towards capitated rates, managed care, which does what, conceptually? Just quizzing you. It's not like a fixed cost, right? Like you're going to get this amount of money to take care of this person per month or whatever it is, and you got to make it work, right? So there's an incentive to do what in that case? Yeah, there's an incentive to withhold care, right? Because the less care I provide, the more money I get to keep in my practice, right? So we're in this constant struggle with trying to figure out, how to provide incentives so that there's a balance there, right? Like you don't want just, overconsumption and overuse of healthcare services. That's actually dangerous, right? But you also don't want to, create an incentive that is so perverse that you end up withholding care for folks who really need it because the financial gain is so great. So we're trying to find that balance of, making sure that we're providing the right care at the right time for that person and what they need in their life, right? And we're still trying to figure that out because it's not been, still trying to figure it out, yeah.
So do you think the cost of healthcare are inflated though? Simply because the insurance will pay for it anyway?
Oh, yeah. Yeah, the cost of healthcare and that's, there are more issues that's a little bit of a complicated question. Why do insurance companies pay these ridiculous prices if the hospitals say that they need to take care of people? Right, like that's another question. Like the whole negotiation between providers and insurance companies, then you throw in Medicare and CMS on top of that, like it gets really complicated. But I think your point is valid. So one way that you try and curb moral hazard, right, or curb consumption, we have to have skin in the game. Right, so if you're just like totally shielded from the cost of insurance, don't have to pay anything, you'll way overuse it. But if they have to charge you too much, and you won't use it when you should, so we're trying to find that balance in there on the consumer side as well. So these are just things that you need to know for your general edification and well-being as a human being, right? So when you go out and get a job and you get your insurance stuff and you have to pick a plan, these are the kind of things you're going to see. So co-payment is the cost that you pay at the time of services. So like when I go to the doctor, I typically have a co-pay. It's like $5, $10, $25 or so on. And it varies. Like if you go to the ER, it's going to be like $100. Why are they going to charge you a co-pay of $100 to go to the ER? Because they don't want you to go to the ER because it's the most expensive place to go. So that's a co-payment. Those are generally not a big deal. Co-insurance. What is that? So co-payment is $5, $10, $20. It's a fixed amount, regardless of how long you're there, regardless of what happens. So what is co-insurance?
You pay a certain percentage of the total cost.
Yeah, so your insurance will cover 80% of the bill, and you're responsible for 20%, right? So, if you have a hospital bill for $1,000, you have an 80-20 plan where your insurance covers 80, you cover 20. What's 20% of 1,000? 200? Right, so you're on the hook for $200. Right, so that's how a lot of plans are structured. So again, 20% is better than 30%, 30% is better than all of it. So that's co-insurance. And a lot of times, like if this gets overwhelming, like if you are in the hospital and your co-insurance is 20%, like you can get on payment. Like you don't have to pay it all at once necessarily. Deductibles. What's a deductible?
The amount you have to pay before the insurance starts paying.
Yeah, deductibles make me mad. Like I hate deductibles, and this is a struggle with insurance, and I can't remember if I talk about this later on, but I will. So I think my deductible, like I have a family plan, the state covers 80, I'm responsible for 20. I think my deductible is like $3,000, I think, which is actually not bad, relatively speaking. Is that right? I think it's 3,000. So it's like $1,500 for me and then $1,500 for my family. So that means every time I go to the doctor, like I have to pay at least $1,500 for me and $3,000 for my family before what? Before insurance even pays anything. Now that's with preventive care. It's a little bit different, right? Like, 'cause I don't get charged for preventive care under the ACA. So like when I take my kids for well child visits, if I go for an annual physical, like those don't get counted. How many times do you think that I burned through my deductible, even with 3 kids? How many times do you think I burned through my deductible in a year, and the insurance actually had to start paying? Not many. Right, anyway, that's why it makes me mad, because it's like, we're relatively in pretty good shape and pretty healthy, and my kids just kind of have routine stuff. So invariably, we end up like $150 here, $150 there, just like if they have a snotty nose or something like that.
So it's like you have no insurance.
Yeah, it's like you might as well not even have insurance, right? Like I can just pay for it out of pocket. What's the problem with that? What's the problem with that mentality? So if I want to roll the dice and be like, we're not using it anyway, what do you think will happen as soon as I do that? So I'll give you a good example. So make sure I don't run out of time here. So here's an example. When I moved to ETSU, it's one of those dumb policy things. When I moved to ETSU, my insurance at the University of South Carolina ran out at the end of the month. Okay, ETSU doesn't allow you to start your insurance until a month after you've been here. What does that mean for me? I had a month when I moved here with 3 kids, right? They're 8, 6, and they're about to be 9, 7, and 5. My little one just turned 5. So 9, 7, and 5. Of course, they were 8, 6, and 3. Well, no. They were 7, 5, and 4. 7, 5, and 3 when we moved. Anyway, you get the point. They're little, right? They do dumb stuff. They whatever. So I had a month where I'm like, you know, they wore helmets everywhere they went. You're walking up and down the stairs for breakfast, you got a helmet on, right? You know, I knew that, you know, that's just the way life works. There's a month. It's like I haven't gone without health insurance since I was your age. And I got this 1 month, and there's nothing I can do about it, right? Like, it's not my fault that you have 2 universities that have different policies. Now, I could have taken out a COBRA policy with South Carolina that extended it for a month, but do you think I would have paid how much? I would have paid the full premium, which is about, I don't know, $2,000, right? So that's it. I rolled the dice. It's $2,000 in COBRA worth crossing my fingers and hope they don't do something stupid in 4 weeks. Right, let me tell you what my oldest one did.
No.
So my 2 oldest ones are girls and my little one's a boy, and you know they like Barbies and they like princess stuff and like whatever. You know what my oldest one did? Kids. She took a little plastic gem from a crown that like a little tiara that fell out. You know what she did? She stuck it in her mouth and swallowed it. And I'm like, first of all, what possessed you to do that? Second of all, you better hope that you poop it out and I see it. Because I'm not paying to have it extracted. Like, that would have been thousands, like that would have been a really expensive procedure. So anyway, luckily there was no obstruction and it just was whatever. But like I was so mad at her, I'm like, anyway. All right, sorry. You have to humor me out. Kids, they're crazy. So this is something that should make you very depressed. Right, so if you go back to the 90s, this is the average annual worker and employer contribution to your premiums, right? So when you look at your premiums, the first thing you need to notice right here is in 2016, $18,000, $18,142. What is that? For family coverage, like for basic insurance for your family, how much does it cost on average across the country? $18,000, $19,000. Let's put that in perspective for you. Chances are, most of you, when you get out of here and find a job, you might be making $40,000 a year, right? Unless you get lucky and whatever. So if you were paying the full cost of family coverage, $20,000, right? And the proportion increase in what you're paying as an individual has increased, but it's also increased for your employer as well, right? So the cost of premiums are going up, your employer's paying more to cover it, and then you're paying more to cover it too, right? Like everybody's paying more, right? That's why people are so mad and aggravated and infuriated about healthcare and premiums and whatever. Yeah, we can't decide on what the best way to fix it is, but everybody's mad about it, right? So again, this just points out that this is the average annual deductible for covered workers, right? So one way to help reduce the financial burden on employers and insurance companies is to make you pay more out of pocket, right? So the average annual deductible, has also gone up significantly since 2006, right? So this is just in the past 10 years. So more increasingly, some of that financial burden is being shifted on the consumers, right? So what's the problem with that? You're the consumer, right? Like you're the one that's getting shifted on. As these things keep going up, what does that mean for you?
Getting care. I mean, you don't want to go with the absent.
Yeah, it's costing you a lot more money, right? And what's the risk of it costing you more money? There are two risks. One is you just say, screw it, I'm not carrying insurance anymore. Of course, then you got the ACA coming behind you and they'll fine you if you don't. Right. The other one is like, I'm just not gonna go to the doctor, and like that may be fine in some cases, but in some cases that's a problem, right? Because that means you're not gonna get preventive screenings, you're not gonna get things, like things are gonna fester until you're so sick that when you finally do go, like the wheels come off the wagon, right? Like not so much at your age, but as you get older. Like that's kind of what happens is that the more financial burden that falls on the consumers, the risk is that you don't get care that you actually do need, right? So that's kind of the problem here. All right, so let's talk about how private insurance markets work, right? So again, if you have a job and your employer is paying 80% of your premium and you just have some type of copay, consider yourself lucky, right? Because relatively speaking, you're in a better position than most other people because you've got a lot of people that are spreading that risk around because you have such a big group that you tend to get off a little bit better. So although it sucks that costs are increasing and whatever, it's still not as bad as it is for a lot of other people. So we're going to play a game here. All right, count off in fours. Like 1, 2, 3, 4, 1.
3, 4.
You're 3.
3, 1, 2, 3, 4, 2, 4, 1, 2, 3, 4, 1, 2,
1. Okay, remember your number. Okay? So, here's what I need you to memorize this very quickly. That's why you only have to remember one number. Right? So, if you're a 1, you're person 1. If you're a 2, you're person 2. If you're 3, you're person 3. You guys get it right, like you don't have to be an epidemiologist to figure out what we're doing here. Okay, now this is kind of a new game. This may or may not work. Your only other alternative is burpees, so we'll try it again. Alright, so person 1, this is your scenario. I want you to think about if you're this person and this is your place in life and this is the situation you find yourself in, which one of these insurance plans would you pick based off of where you are in your hypothetical scenario? Now I'm going to show you the different plan options in a minute. I need you to internalize this. They'll put on your actor role and like this is who you are. So person 1, you're 27 with a college degree. Right, that's not too far-fetched. No significant health issues other than just like a routine cold every now and then, no big deal. So you're really pumped because you finished graduate school, you landed your first job working for a nonprofit, but it's a small nonprofit, but it fulfills your life's mission and you're happy. But they don't offer health insurance, so you have to go buy it. So if you're number 1, that is your life's plot. Okay, so I want you to think about what that would mean for you and what type of insurance plan you might be interested in. Person 2, if you are number 2, you're person 2. So you are 32, which sounds old to you now, but it sounds young to me. 32, you're married, you don't have kids, but you're at the point in life where you might think about it, right? Like that's a personal decision. You don't have to have kids to be fulfilled, but you think that you might want them. No significant medical issues. You work for a small company. You and your spouse work for small companies, so you have a stable middle-class job. We're just going to assume that your income is $50,000 across all these, right? So you're working for a small company that doesn't provide health insurance, which is actually fairly common. Okay, so you have to buy health insurance, or maybe you have to buy health insurance. So that's your plot in life if you're person 2. You're person 3. You're 45, which sounds very young to me. They don't get that yet.
They will.
They will. Person 3, you're 45, married, you have 3 kids. You can think about where I got this scenario from. Actually, not, because I don't have any of these. You know, you're 45. What typically happens with a lot of folks is they age and they hit their 40s. Kids are tough. Life is tough. You eat bad. You don't exercise. So you end up scratching your head, thinking, "Wow, I've got some problems here." You go to the doctor. You have borderline diabetes, borderline hypertension. They want to put you on some medicines to help get those under control, because that's what they do, is to tell you to get off your butt and go exercise and eat right, because we treat symptoms and don't address the root cause of the problem. Sorry, that was facetious, and I should have said that. Same situation. You work for a small company, you don't have insurance, but you got to figure out something, right? That's where you are. Person 4, you're 59, you're married. You and your spouse both have chronic conditions that you're dealing with, right? So maybe hypertension, diabetes, starting to get sick a little bit more, some osteoarthritis, things that typically happen as you age. So your company, you had a good job, you had insurance, your company moved because that's what happens nowadays, and you didn't want to move with your company because you're close to retirement, so you got a new job, but your new job is a much smaller firm, and they don't offer health insurance, right? So I want you to think about that, right? Like whatever you got to do to get into your space, and think about what that scenario, how would you make decisions, right? Like if you talk about health insurance, given your scenario, what will go into your decision making? So you have to pick a plan. I want to see how this shakes out. I'm just curious. Like if y'all don't pick like I think you'll pick, we're just going to have to do burpees. So plan A, you roll the dice. Maybe you get fined a couple $100 by the ACA because you don't carry insurance, but you're willing to roll the dice. The fine from the ACA still is way less than it would cost you to buy insurance, so no big deal. Plan B, your premium is $150 a month, right, which is not bad. It covers catastrophic illnesses, hospitalizations, right? It's not going to cover your basic doctor visits, but it's going to cover serious stuff. You have a $5,000 deductible, and you have a health savings account option, right? That's Plan B. Plan C, your premium is $600 a month.
Jeez.
Per individual or for the
For the family.
Oh, okay.
Your deductible is $4,000, and you have a copay of $15 to $25 a visit. Now again, think about your scenario, where you are in life, how much you think you'll use it, what type of value that would provide to you as an individual. Okay, that's Plan C. Plan D, your premium is $900 a month. Again, your employer's not helping you at all. Like you just have to suck it up and buy it. $900 a month. Your deductible is $2,500 a month. And your copay is $5, $10, $15 a visit. Okay? So I'm going to give you like 10 seconds to think about, based off of your scenario, if you're person 1, person 2, person 3, or person 4, which one of these plans would you choose? All right, you're on the clock. 10 seconds. Which one makes the most sense for you?
Did you say the deductible is per month or per year?
Deductible is every year. So your deductible is what you have to pay before your insurance pays, and it starts over every year. So if I burn through my deductible and the insurance starts paying, then the next year it starts over and I have to pay my deductible again. So that's an annual thing. All right, you got it?
Yep.
Okay, so all my number ones, I actually need a cross. All right, all my number ones, raise your hands. Okay, put them back down. How many of you pick A? How many of you pick B? How many of you pick C? How many of you pick D? You're a risk-averse dude. All right. All right, where are all my twos? All right, twos. How many of y'all pick A? Look at that. Rebel. How many of y'all pick B? Oh, wow. 1, 2, 3, 4, 5. How many of y'all would pick C? How many of y'all would pick D? All right, where are my threes? Okay, A. How many of y'all picked A? How many of y'all pick B? How many of y'all pick C? How many of y'all pick D? All right, my fours. Okay, how many of y'all picked A? B? C? D? All right, can y'all see the board? Okay, so our number ones, so our young, educated, nonprofit, no insurance folks, most of you, some of you roll the dice, but the majority of you pick Plan B, which is your high deductible health savings plan option, right?
Could you explain this HSA option for some of
The HSA stands for Health Savings Account. That's where you take your income and you put it in a tax-free account, and you use that to pay your doctor bills. Right. It's like saving 32 cents for every dollar you put back because you don't have to pay taxes on it. Anyway, that's beyond the scope of this class, but so, right? So the majority are young, healthy folks, educated, feel confident that you can manage an account, whatever. You all picked B. All right. So our early adult folks, 32, married, no kids, no significant health issues. You all mostly picked B. So you still feel like the high deductible health savings plan account would work for you, but a little bit more towards. A few of you picked C, which is a $600 a month premium, decent sized deductible but low copays, right? Okay, so our threes, right? You're getting a little bit older, you're not doing so well. You're probably about to run into some problems. You all picked C and D, right? So decent sized premium, high deductible, whatever. But some of you started leaning more towards D. Right, a little bit higher premium, lower deductible copays. Okay, our fours, you're about to hit Medicare, but you're hoping the wheels don't fall off the wagon until you get there. Most of you all pick D, which is your, decent premium, lower deductible copay plan. See what's happening here?
Whoa.
You don't have to do burpees today because this worked out just right. All right. So, what's happening here? Actually, you get the point. What's happening here? Somebody summarize it for me.
More expensive insurance gets.
That's true, but what else? Right, so all you younger, healthier folks, even some of you middle-aged, not have kids yet, what went into your thought processes behind what you selected? You can't tell me what went into your thought process?
I mean, the way I looked at it, if I go back to here, so I would have paid about 3,400 USD for that year, compared to paying 5,150 in a year. I mean, I can see, since I have a job, I can see I have to pay $900 premium.
Yeah.
Plan D.
Yeah.
So
You're an outlier, right? Like you're the only one to pick that plan.
Yeah, I'm explaining the rationale.
No, I agree with your rationale.
Oh, yeah. So they will still plan B will still continue to pay, up to 5,000 plus. Why? Once I get to 3,004, I stop paying. Except for the
So
co-pays.
you look at deductibles, right? Because if you look at the deductibles, you're 900 over the course of 12 months, a couple of years deductible, right? Like that makes sense. Right? That's a little bit more of a risk averse approach, right? Like you're probably a little bit more scared if you're gonna have some issues, right? What are your thought process?
As number one being 27 and just like starting a career, I thought a lower premium every month would be better because as you're starting, your salary is not as high as it can be. So $900 a month is a lot as you're starting a career. So, and if we're healthy and we have no health risks, a high deductible.
Yeah, you're not quite like one of the doctor very much, right? So you would rather just pay a very minimum amount to make sure that if you're in the hospital, you're covered. But for the most part, you want to keep as much money out of your paycheck as possible because you know you're not going to use it, right? Is that how many of our number ones kind of felt that way? Like that was your logic, like your rationale. Any other diverging thoughts about our number ones? No.
Oh, I have one.
Yeah.
I think that if in doing cost analysis, a young healthy person could, in terms of their own budgeting, arrange their budget with the philosophy of public health and spend more of their money on like healthy food or like a gym membership and things to like maintain their well-being.
That's a good idea.
Then like paying $500 a month or $600.
Are you community behavioral health major? Yeah, that's a good point, right? Like keep more of your premium, keep more of your own money and invest it in making yourself a better human being physically, right? Alright, we're gonna run out of time if I'm not careful here. Where are we? Our number two folks. So married, no issues, right? I think I kind of summarized what your thought processes were. So let's hop over to this other side. Our 3s and 4s. What's your logic here?
So I chose C because D is preferable, but if you have 3 kids and your own health issues, you're gonna have a lot more to pay than just for your medical plan, probably. So C is most cost-effective lifestyle-wise.
Yeah, that might be a little bit more cost-effective, right? What about our 4s? All you, the 6 of you 4s that pick D. What went into your thought processes?
Getting old.
Yeah.
My moral hazard is shameless.
Yeah, that's a good point, right? Like that's exactly it. Why did you pick that one?
Low deductible and
The deductible's lower. You know you're going to go to the doctor because you got a lot of stuff going on. That $900 premium doesn't look so bad because you know you're going to have to go. Like when you throw in like the cost of medication, right? Like that $900 a month is looking a little bit not as onerous because you know you're going to use it, right? Okay. So let me ask you this question. All of you who pick number D, so there's a pretty high correlation between your health status and what? Which plan you picked. If you're an insurance company, Why would you be freaking out right now?
The quicker people choose the less deductible plan.
Did you guys hear that? Did you catch that?
Yeah. No.
Right, if you're an insurance plan, if you're an insurance company, which one would you want to offer? What, let me back up and say it this way. If you're an insurance company, how are you going to determine how much to charge these people? So, okay, let me back up and say it this way. Insurance companies will offer multiple plans, right? So you'll have an insurance company that will have an A, they'll have a B, they'll have a C, and they'll have a D, like the same insurance plan. It's just a different group. How do you determine what you're going to charge people in A versus what you're going to charge people in D?
Their age,
Their age, what else?
their health conditions.
Medical condition,
Their
medical conditions,
right.
no family size. Yeah.
Family history, family size, they smoke, what kind of underlying health issues they have, right? How much of a difference, well, we saw the difference, right? Like there's a big difference in premiums here. So let me ask you this question. Prior to the ACA, how much variation do you think that there would be between the premiums for an insurance plan across the country? Same plan. So let's just say 80-20 plan, standard plan. If you are a young, healthy person that chose that plan versus an older, sick person who chose the exact same plan, how much variation do you think there is across the country in that premium? So let's just say $1,000. So let's just start with 1,000. How much more, if the standard premium was $1,000, how much more do you think that an insurance company could get away with charging a different person for the exact same plan based off of all those criteria you listed? How much variation? I'm sorry, I'm doing a horrible job asking that question. Do you think it's a lot? How much a lot? So 1,000 is the baseline, and if you have a really sick person who wants the same plan, how much more do you think they can get away with charging that person? Double? So they charge them 2,000? Anybody want to guess? Put a dollar figure on it. What's the most you can get away with charging somebody like that?
10,000.
All right, I'll put you out of your misery. Since I asked the question very poorly, I'll take responsibility for the answer. There's about a 17-fold difference across the country between the cost of plans based off of those criteria. So they can charge somebody, a young, healthy person in Texas, $1,000, and they can charge my parents in West Virginia, which is a poor market, $17,000. Exact same plan, right? How do they determine that? I'm looking for a specific term here. How do they determine that? You all listed all those criteria, right? Like your age, how much you're going to cost me, pre-existing conditions, like all those things. What is that? There's a term for that. It's called medical underwriting, right? So when you apply for insurance, they're going to look at your health history and estimate what you're going to cost them. There's a technical term for that. It's called experience rating. It's exactly what it sounds like. They're giving you a premium based off of your experiences, your life experiences. Because again, you know, you're trying to protect yourself against risk, but the insurance company has no way to know how sick you are. So they're trying to protect themselves from a financial risk, right? Underwriting is they're trying to predict what you'll cost them, and they use that to set your monthly premium, right? Like that's how insurance in the private market works. So you all, 4 different groups of people, all go into the private market. You're selecting a plan based off of where you are in life and how much you think you're going to use it, right? The insurance company has no way to know that. So insurance is designed to spread the risk. So all of my 4s over here, when you're spreading the risk, you need, you know you have expensive people in the plan. What do you need in your plan to offset the expensive people?
The younger people.
The younger people. Which plan did you all choose? Not the one that's going to help them offset their costs, right? Like that's kind of the point here. So that's an issue. So The insurance company has no way to know this, right? So you end up with a lot of people that are sick in the same plan. What does that mean for spreading your risk across the group? You're all sick, you're all not well, you're all going to cost them a lot of money. So what does that mean for the premiums in that group? They're going to go up, right? So what does that mean if you all pick the high deductible plans or these lower plans? You got a lot of young, healthy people spreading the risk. What does that do for premiums? Keeps them down. They're not going to go down, but it keeps them from going up too much, right? You see what's happening here? All you young, healthy folks congregate in the one insurance pool. All the sick, older folks congregate into another pool. The premiums are charged based off of the distribution of risk within those pools. If your pool matters, right? So like whichever pool you end up in is going to determine how much you pay for health insurance. So what happens when all the sick people end up in the same pool? We already established that. Premiums go what? Okay. What happens when premiums go up and you have a lot of income-sensitive folks paying $17,000 for an insurance plan in the private market? What do you think happens? Yeah, at some point it's like, I'm done. I can't afford it anymore. I'm just going to not carry insurance. And as a human being, it bothers me that I'm not going to be able to pay for it, but I can't afford the insurance, so you drop out. What does that do to everybody else in your pool when you drop out? It gets more concentrated with more sick people, right? Like it gets worse. What happens then? More people drop out. When those people drop out, what happens? Right? How many times I have to go through this before we understand it, right? You guys get it. Okay, that's the issue here. That's called risk pooling. Actually, that's called the death spiral of private insurance, right? Like that's the problem with the private insurance market. It's a death spiral. Premiums go up, people drop off. Premiums go up higher, people drop off, and it gets out of hand very quick. So risk pooling and spreading risk is a big deal. Your insurance companies, they set your premiums based off of what it's going to cost them. So they have to pay their claims, cover their administrative costs, and build in a profit. That's what goes into your premium, right? Think about that for a minute, right? Like they build their profit into your premium. So now, here's an important issue. That's the private insurance market. If you go try and buy it in the private market, that's the way it works. Does it work that way for me as an employee of the state of Tennessee? No, I'm in a great big group with a lot of people, and we get a community rating scheme, which means that we all pay the same thing or a similar rate within a very defined bound. Okay, if you go to the private market, you're experience rated, which means they look at your medical history and charge you a premium based off that, of which you're paying the full cost of because you don't have an employer to offset it. So do you see why nobody buys private insurance? Right, or why prior to the ACA, nobody bought private insurance. Like it was insane. So basically what happened with the ACA, I'm going to give you all a break. I know you guys have been really good. I'm going to give you a break here. Just let me finish this point. Prior to the ACA, there was an experience rating scheme where like your low-risk folks, your A's, were over here. They didn't get charged much. Your moderately risk folks get charged a little bit more. Your high-risk folks end up in a pool where they're all paying a lot more. That's experience rating. What the ACA does is implemented a standard community rating scheme for all insurance plans sold through the private market. So insurance companies can't do that anymore. They can't look at your medical history. They can't charge you 17-fold difference between whatever. It's standardized that. They can charge you a certain premium based off of a set plan. Some of it's anchored against your income. There's a little bit of variation, so they can adjust it for where you live, how old you are, whether you smoke or not. Right? So they can't look at your whole medical history and charge you $17,000 for what they'll charge somebody $1,000 for. So that's what the ACA did in the private insurance market, right? So this was designed to entice people back into, like people who don't have insurance. It was designed to create a market for them, or they can get a similar insurance rating scheme as what the folks who have group insurance get. Now, you still have to pay the full cost unless you get a subsidy, which we'll talk about next week. But it's designed to level the playing field a little bit within the private insurance market. That's what the ACA did. This class is not on the ACA. We're going to talk about that next week. I'll go into a lot more detail, but I'll just say this to kind of frame it up, and I'm not going to go into a lot of detail real quick. I know you guys need a break. The point is that less companies were offering health insurance prior to the ACA. Like we saw that going down. Fewer people were taking them up on it when it was offered, right? Then you had the recession that came along and unemployment goes up at the same time that less access to group insurance is occurring. So that translated to a big jump in the number of uninsured and the number of folks that were enrolling in Medicaid, particularly kids, right? So parents would go without health insurance, they would put their kids on Medicaid. So that's what we saw leading up to the ACA. And I'm going to throw this in there just to make you mad. So this line right here is the average annual increase in insurance premiums over time. This bottom line right here is the average increase in worker wages over time. Okay, what do you need to take away from that? When you get your paychecks, I promise you'll understand it. What's happening? Why is it such an issue?
The amount you're paying compared to how much insurance rate is going up.
Let me put it in plain English. Every time you get a raise, you end up paying more money because your insurance goes up. Right? So you may get a raise of a couple $100 a month, but then your insurance premiums go up 3 to 1 compared to what your wages go up. See what's happening? So you're working hard to get ahead and making more money and doing what you got to do, but more and more of that money gets sucked back out because it costs so much to pay for health insurance. Like that is the plot of healthcare in the U.S. That was leading up to the ACA. Shifting economy, poor uptake, more leaning on public insurance. So here, all right. 2:30. What time does this class get out? 3:30. Oh, I got a lot of time. Oh, all right. I was afraid I was getting behind here. So let's do this. I'm going to give you 5 minutes. Okay, right. So that is part 1. So I need you to go, like, get some water, go to the bathroom, take a lap around the building, do some burpees, do some push-ups, whatever you got to do. Come back in 5 minutes and we're going to shift here and talk about public insurance.
I can start like an email thing. Yeah, I was just wondering if we should like get it. I mean, our talk's due next Sunday, so I feel like that we just next Sunday. Yeah. So I think we could just email about the good topics and after that, like if we start doing stuff. Yeah, no doubt. But we definitely need to get something started. Yeah, before we like get on the okay. But that's till next Sunday. Yeah, it's like the 20th. Yeah. That's cool. House out here, just to get out of this.
All right. Do you have any questions? Contemplations? Internal turmoil and struggles? Anything you want to talk about before we move on? You guys let me turn this around.
Yeah. Kind of a question.
Yep.
Do you think this a deal can be made?
On healthcare? What kind of question is that?
Why are we discussing it? I'm not looking for a solution.
We'll talk about the solutions more next week. We'll talk about the ACA. Because that gives us talking about the ACA gives us a framework to look at how it was before, how the ACA is. Because we had enough time that's gone by with the ACA where we know what works and what doesn't. And then I'll kind of frame that. Give me that. Can you talk to him? I'll frame that in the context of what the alternative solutions are. We kind of talked through what those may be. The short answer is I am not holding my breath.
With the ACA and how that affected the community rating, my question is, did the government influence the profit margin of the companies? Like, in what ways was that economically viable for?
Yeah, so that's a good question. Write it down and I'll answer it on next week. The short answer is they set a medical loss ratio that all insurance companies have to meet, which means that only a certain amount of money that they're making, like a certain proportion of it had to go to pay for medical bills and couldn't be dumped into like profit and stuff like that. But like that's one part of your question. The other question is how in the world would insurance companies make money by offering these plans in the marketplace, knowing that it was primarily sick people who were going to be buying those plans, right? Like that's really the question in a lot of ways. What's in it for the insurance company to offer a community rating scheme in the exchanges? And the short of it is the federal government gave them effectively a premium offset. And basically they gave them they gave the insurance companies a subsidy. It's called a premium stabilizer. So that when they ended up with a lot of really sick people, then that would help offset their medical losses for taking care of those people. What happened during the election year this past year? You guys keep up with that kind of stuff? What was the wailing and gnashing of teeth that was happening around healthcare premiums during the election year? The premiums in the market. They went up. Why did the Obamacare market premiums go up so much that year? I just gave you the answer to the question. Those subsidies ran out. Like there was a window on the premium stabilizing subsidies of the insurance companies. As soon as those ran out, the insurance companies, y'all don't get me started on this. They're trying to act like they had no idea that they were going to end up with this many sick people in their plans. And now they're all wanting to pull out of the market, right? Like several of the major insurers are wanting to pull out of the Obamacare markets because they're losing money. That's bullcrap because they posted record profits since the ACA collectively as an organization. Are they losing money on the ACA? Yes. But as a whole, are they making money? Absolutely. Right? So what happened is these premium subsidies went to the insurance companies as soon as they went away. Now they're like, we don't want to play anymore. It's nonsense, in my opinion. You're free to disagree. I want to stop there. All right. Any other questions that don't get me off on a whatever you want to call it?
You got a full meaning for ACA?
What?
ACA.
The Affordable Care Act, it was the Healthcare Reform Act in 2010. I'll talk about it next week. It was a major piece of legislation. I'll just say that. My name is You are killing me. I try really hard. As a matter of principle not to. You'll know when something's my opinion versus what's objective. Right? So I try really hard not to use my influence to sway your thinking. I want you to be able to look at the merits of the arguments for what they're worth and make your own decisions, right? Like that's what college is supposed to do. So I'm not going to answer that question. There are good parts and there are bad parts. I'll just say that. You guys are like throwing me loaded questions I'm not going to answer. All right. So, talking about public financing sources, right? So this is a big deal, right? Because what do we know about public financing over the years? Has it gone up or down? It's increased, right? So this is important. So when we talk about the public financing of a healthcare service, we're talking about Medicare, Medicaid. Those are the two big ones, right? Like, I mean, there are other ones like, TRICARE for the military and things like that. But for the most part, we're talking about Medicare, Medicaid. So we're going to talk about those. And I really want to talk about how they're financed because that's really critical for the discussion here. And a little bit about spending. So Medicare is what? Who's covered by Medicare? 65 and older.
And permanently disabled.
Is that it?
Permanently disabled.
The age, blind, and disabled are also covered under. If you have end-stage renal disease, regardless of your age, you're covered by Medicare, right? So it's not just older. I mean, that's primarily who it is, but there are other criteria. Like if you're on disability, you're covered under Medicare, right? So it's not just the elderly, but that's primarily who it is. So this is important. Medicare is an entitlement program based on age, which means what?
When you turn 65, you're entitled to get Medicare.
Regardless of where you live in this country, regardless of how much money you make, regardless of anything, when you turn 65, guess what you're eligible for? Medicare. Right? Medicaid is an eligibility program for who?
Low-income families.
Low-income families, right? Is it just low-income families? Good question. Children, women, who else?
Isn't the elderly also entitled to Medicaid?
Yes, the dual eligibles that we'll talk about in a minute, right? Medicaid is, I do a lot of research around Medicaid, so we'll talk a little bit about that. So, the difference between eligibility and entitlement is what?
You have to be eligible.
One year guarantee, 1 year no.
Yeah, I've heard a couple different. Yeah, that's just like entitlement. You get it no matter what when you turn a certain age. Eligibility means you have to meet certain criteria to be eligible. Like, and those vary from state to state. Right? There's a lot of variability in Medicaid eligibility. We'll talk about that in a minute. So it varies by state. Importantly, who runs the Medicaid or who runs the Medicare program? Is that a federal or state program? Federal. Who runs the Medicaid program?
Both.
Trick question. Both. Yeah. Where is the locus of control for Medicaid as far as determining eligibility, determining criteria? Who controls that? State. So Medicare is an entitlement program housed in the federal government. Medicaid is an eligibility program housed in the states. But the federal government pays a lot of money to help support the Medicaid program, and I'll show you that in a minute. Let's talk about Medicare. It's not that simple, obviously, or it wouldn't take us an hour and a half to talk about it. So Medicare was passed in 1965 under Lyndon B. Johnson, kind of tied with some of the civil rights movement stuff. Guaranteed access to insurance if you were elderly, regardless of your financial circumstances, right? So maybe you all can help me explain this. In the 60s, why Medicare and why 65? Why? Is it just because we felt sorry for old people? What was the deal? Why would this be so important for the elderly? It's when they retired. That's when what starts to happen? Social Security, right? What happens when you get older? You get sicker. You use a lot of resources, right? What have we already established about the cost of those resources? Right, so you're old, you retire, maybe you've got some money put back, maybe you don't. Right, how fast do you think you would burn through your retirement if you didn't have insurance when you retired?
Very fast.
Yeah, you last not very long. Right, so the point here is that part of the reason that Medicare was passed was that a lot of seniors ended up going bankrupt and living in poverty. Like, these are seniors who worked their entire life, okay? These are not like people just kind of sitting around, whatever. You can work your entire life, work at a company, be taken care of, and then whenever you retire, that's gone. And when you have to start paying for your own doctor bills, it did not take long for a lot of seniors who lived a respectable, working class, middle class lifestyle to end up dying in poverty, completely void of resources because they had to spend it all to take care of themselves, right? So there was this movement around, we can do better, right? Like, these are people who work their entire life. We should take care of them, right? What was life expectancy in 1965? You guys got phones, you can Google it, right? What's life expectancy right now? Let me just say this one. 70 what?
77.
79. Current life expectancy is 79. It's different for men and women, but it averages out at 79. What do you think the life expectancy was in 1965? Was it 79? No, it was in the 60s, right? So when this was passed, right, now keep this in mind. So I'm going to cut to the chase and give you the punchline before I get there. This ended up costing a heck of a lot more than it was originally anticipated, right? So let's not pretend like it didn't. But the idea was people retire, they're going to live for a few more years, maybe 5. We can offset their health care costs for a short period of time. They can die with dignity, maybe leave a little bit of money to their family. It's all good. People retire, now we live 10 years longer. Right? How many more resources do you think you consume in those last 10 years? Yeah, so you see where this is going, right? Like what started off as a noble altruistic program to take care of seniors because we wanted them to die with dignity is turned into a really, really big entitlement program that takes up 14% of the federal budget, right? So anyway, the point is that Medicare combined with Social Security kept seniors out of poverty. Right, that was the gist. So about 16% of the total population, about 55 million folks are enrolled in Medicare currently. This is increasing with the baby boomers, which you already established who those people are. So about $675 billion in spending in 2016, right? So this is a big program, and it costs a lot of money, right? I'm not saying that that's bad, it just is what it is. So as a percent of the federal budget, Medicare accounts for about 14% of the entire federal budget. So 14% of every dollar in the federal budget goes to Medicare, right? You think that's going up or down? Up, exactly. So, interestingly enough, I don't want to get into too much detail on this, but so this is Medicare spending, actual spending between 2022 and leading up to the ACA. Spending was increasing about 9% annually. Under the ACA, Medicare spending has actually been, like the rate of increase is much lower than what it used to be. There's some things in the ACA that are designed to help control costs. That's where a lot of that's coming from. Not really want to say too much there. Not even really sure why I put that in there, but you know, thought it was cool. That's fine. So Medicare is a umbrella term that's actually comprised of 4 different parts, right? So there's the original Medicare that was passed. Original Medicare was Part A and Part B. So Part A is what? It's on the screen. You can read it. Hospital insurance, right? So every senior, when they turn 65, you don't even have to sign up for it. You're automatically covered for hospital insurance. So if you go to the hospital, Medicare is going to cover it. Well, it's not quite that straightforward, but just for the sake of argument, it is. Part B, right, so that's just hospital stuff. You know, seniors go to the doctor a lot. How many of y'all have had to, like, shuttle your grandparents around the doctor's visits, right? Like, yeah. So seniors use not just hospital facilities, but they use physician facilities. So Part B is optional. Like, it's optional coverage for physician visits and outpatient care. Okay, so it's optional. The premiums are like ridiculously low. It's like $100 a month to enroll in Part B, or like $133 a month. I'm going through this with my dad. Like, I'm helping my dad sort through this stuff right now. It's like $133 a month. So for $133 a month, you can have your hospital care covered and your physician outpatient visits covered. Now, we'll talk about this in a minute. It's not free. Like, a lot of it's covered, but there's still some cost sharing involved, right? So that's the original Medicare. Now, subsequently, they've added different components of Medicare. Like Part C is Medicare Advantage. That's a managed care component. So if you're a senior, you can enroll in a managed care under Part C, and you pay one premium to that group, and they pay for A, B, and D, right? So you just have to pay one person, and they kind of take care of making sure that everybody gets that money. So a lot of folks who don't mind their care being managed may enroll in that. Part D is a prescription drug benefit, right? So that was passed under the Bush administration. Obviously, the big issue with seniors is access to medications, right? Like they take a lot of medicines and they're not always cheap. So under the Bush administration, they passed the Part D benefit. He had some significant issues early on. The ACA kind of filled in some of the gaps with the prescription drug benefit, but anyway. So the point is, you have A, B, C, and D. All of them are important for different reasons. So again, Medicare is not free. There are certain out-of-pocket costs, right? So you still have premiums, you still have co-pays, you still kind of have those things, but they're not too onerous. For the most part. Now, there are gap policies out there, right? Like you can buy private insurance plans to help you offset the costs of Medicare, like, it just kind of gets back and forth. But the Center for Medicare and Medicaid Services, CMS, is the federal agency that's kind of responsible for the oversight of Medicare. So, this stuff is fascinating. I hope you find it as interesting as I do. I doubt that you will. But this is important to know. Because I didn't know this when I was at your age. So I think it's interesting. Where does funding for Medicare come from? Taxes. And what? How many of y'all get a paycheck right now? You ever looked at it? What comes out of it? Like federal income contribution, FICA, right? What else is in there? Medicare, Social Security. I remember when I got my first paycheck, I thought I was going to be rich. I was like, what is all this? And you get 66% of what you actually made actually goes in your bank account, right? Do you understand what's happening there? Why are they taking that money out of your paycheck?
Hey, other bills, stuff.
Why are they taking that money out of your paycheck?
It goes directly to Medicare.
Yeah, you're paying, the taxes they're taking out of your paycheck goes into these pots of money that pays for Medicare for who? Is it paying for you?
No.
No, you're paying for your grandparents, your parents. Now, eventually, the idea is that when it's your time to get Medicare, your kids and grandkids will be paying for your butt to be in the nursing home, right? Like, that's just the way it works. So anyway, those are the different sources of funding that go into Medicare. There's general revenue, right? So like when the government goes through a budgeting process, they'll outlay a certain amount of federal funds that go into a pot. There are payroll taxes that account for about 38% of that. So that payroll taxes, so when you get a paycheck, they're pulling 2.9% out of your paycheck right now, and that goes into the payroll tax that goes into one of the funding sources for Medicare. And then they're enrolling premiums, right? So I told you that there are premiums involved, so that accounts for about 13% of the money that goes in there. So general outlays, payroll taxes, and premiums that people pay. Those are the three sources of funding that pay for this ginormous program that's 14% of the federal budget. So here's what you need to know. 85 to 90% of all funding for the current enrollees in Medicare comes from who?
From us.
Comes from you. Everybody that's under 65 or working right now, you're paying for the existing Medicare program. Right, so this is the breakdown. So 41% is general revenue, tax revenue that gets outlaid by the federal government. 38% comes from those premiums of people who are working right now. Right, so almost 40% of the money that pays for the entire program comes from your paychecks. Right, 13% from premiums, and there's there's a trust fund that earns interest and things like that. So here's what's fascinating. Part A is what? Hospital care, right? So just the Part A, again, this was the original Medicare. All that money that's being generated from taxes, right, from payroll, let me back up and say it this way. 87% of all the funds that are being spent on hospital coverage are coming from payroll taxes right now. Okay? And it goes into a trust fund that accumulates. What do you think's happening to that trust fund right now? I need you to think through this. You're graduate students. You got to figure it out. What's happening here? What do we know about the shifting demographic?
It's getting bigger,
Older.
the population's aging.
Population's aging because everybody liked to have a little fun after the war and we had a lot of babies, right? So you had the baby boomers retiring, so you have a big influx of folks who are hitting Medicare right now. Where's the majority of that funding coming from, particularly Part A? People who are working right now, people who are 65 and under. What do you think is happening to that demographic?
It's not as big.
We're shrinking.
Yeah, most of us don't want to have 15 kids. We just want 1 or 2, maybe 3. If you have a couple accidents, nobody's good. That didn't happen to me. Actually, it did. There's a demographic shift, right? Like that demographic shift is a big deal because you don't have as much revenue coming from payroll taxes that you used to that goes into that trust fund that pays for Medicare. Right? You see what's happening here? There's an imbalance that's been emerging for several years. That's a problem. So like Part B and Part D, those kind of get federal outlays, right? Because they're special programs that came after. But this trust fund, how much money do you think is that trust fund? When's it going to run out?
That's great.
The year fluctuates depending on, from year to year, depending on revenue and whatever. But like as of recently, that trust fund to pay for Part A is set to run out about 2030. So I will be, what is it, 28, what is it right now, almost 2018? So that is how many years from now? 12 years, so I will be,
57.
I'll be 52, or 40, right? So it's, I'll be 52 when that trust fund starts to run out. So all that time they've been taking that money out of my paycheck. By the time I get there, it's going to be gone. Like that's not, that's what's going to have to happen in 2030?
We know the percent of baby boomers paying.
What's going to have to happen in 2030? What are your options? Huh? What are your options? Are you? Let me back up and say this way: they're going to let Medicare run out, right? So no, because it's a short-term problem. What happens when the baby boomers die off? It settles back out, right? So like, there's just this kind of hurdle that we got to get through, and then it'll settle back out, hopefully, assuming that things don't, blow up and whatever. Their only option, they're going to have to raise tax. They're going to have to come up with revenue from somewhere, right? Like they're not going to cut Medicare because why are you never going to cut Medicare? Why would you never cut Medicare if you're a politician?
Because you're a baby boomer.
Even more self-centered than that. Old people vote, right? Old people vote, and if you take away Medicare, you're not going to last very long. Medicare is actually really good insurance, right? Like my father-in-law has hit Medicare. He loves it. Like he's like, this is the best thing ever, right? So, because he's had to buy, insurance in the private market through his whole life or whatever. So, Medicare, despite what you hear and despite, there are some issues in Medicare and this and that, but for the most part, it's wildly popular among seniors, right? So, you're committing political suicide if you vote to get rid of Medicare. Now, if you're a Bernie Sanders fan, he wants Medicare for everybody, right? And we just take care of the problem, but what's the trade-off? Yeah, like it's going to come at a cost. Now, some people are okay with that. Like, the cost will come off the backs of people who make more than $250,000 a year, and some people are okay with that, and some people aren't. But anyway, those are illustrated with the larger dialogues around healthcare and healthcare reform, right? Like, you can't just extend coverage and provide these services to that many people without getting the money from somewhere, right? So it's going to come from somewhere. Either it's going to come from taxes. It's going to come from reduced, salaries. It's going to have to come from somewhere. Those are the Those are the dialogues that play out within the policy arena. Like, those are the decisions that have to be made. And we all kind of have different perspectives, different life experiences, different paradigms that we work from that shape how we feel about that, right? Like, it's not that one is right or wrong. Like, that's not what we're trying to get at here. It's just that there are trade-offs. And some people feel like one set of trade-offs is worth it, and some people feel like it's not. And that's what we have to figure out how to come to terms with in the U.S. Right. So anyway, that's a little bit about Medicare and how it's financed. Right. You guys have any questions before we hop on to Medicaid? No? Let me tell you something about old people. At least in my family. All they want to talk about is Medicare and how sick they are. Like, for real. This is my list of doctor's appointments for their social life revolves around going to the doctor. It's true. My grandmother died about this time last summer. And, not even a week before she died, they live in South Carolina, so my family, I took some time off and just went and hang out. And I'm telling you, man, I wheeled her around to 3 different doctor's appointments that week. It was crazy. But that's the thing about grandparents, right? Every single place I wheeled her in, first thing, this is my grandson. He's a professor. They're just so proud of you, right? So anyway. I only say that because I'm not trying to beat up on old people, and I'm not trying to be disparaging by calling them old people. I don't want you to misinterpret what I'm saying here. Seniors are important to our society. I think they should be respected. If you have enough humility, there's a lot of wisdom to be learned from seniors and old folks. So please don't misunderstand my trying to be funny and calling them old people and stuff like that. It's coming from a place of sincerity, not malice. So I just want to make sure we're not. Okay. Sometimes I say things and I get a little bit wound up, but you know what I mean. All right, Medicaid. So Medicaid was passed in 65 in conjunction with Medicare, right? It's a means-tested entitlement, which means what?
Not to be forced to get it.
Yeah, you have to be below a certain income threshold to qualify for Medicaid. So historically, it's mostly been single parents, the elderly who are so dirt poor they don't have anything, the blind and disabled. So what happened was that since the 1980s, Medicaid has become a policy tool that's available to policymakers to expand coverage, particularly for women and children, because as a society, we tend to make value judgments, on people, right or wrong, and for various reasons, folks don't want kids to go without insurance, right? Kids are innocent, kids, you shouldn't punish kids because their parents don't have the ability to provide for them in a lot of ways, or, it's a little bit more complicated than that, but there's always been a, bipartisan effort around making sure that kids have insurance. So what ended up happening with Medicaid is that kind of, by default, extends to who? The mothers, right? Because if you know that a woman is pregnant and you know that she's going to have a child, and you know they're going to be eligible for Medicaid when they're born, where do you need to invest in if you're Medicaid? You better take care of the pregnant woman, right? Or you're going to end up paying a lot more money down the road if the child is born with a low birth weight or something like that. So by default, you kind of have this mother-baby combo that Medicaid has kind of evolved into as a policy tool over the years. So about 15 to 20% of the population, on any given year is enrolled in Medicaid. So, you're talking about 1 out of every 5 folks that live in this country end up qualifying for Medicaid. So it's not quite as expensive as Medicare. It accounts for about 9-10% of the federal budget, but it's still a significant chunk of money. So we'll talk a little bit more about the way Medicaid looks now next week. But previously, there are a couple different ways you can qualify for Medicaid. They kind of fall into 2 categories. One of them was, for lack of a better term, called categorical eligibility, right? So if you're a pregnant woman, let me back up and say this way. To qualify for just routine Medicare, you have to be like, some states it's as low as 50% of the federal poverty level. Some states as high as 400%, right? So like in Arkansas, for example, prior to the ACA, to qualify for Medicaid, you had to be at or below 50% of the federal poverty level. You know how much money that is a year? Like $9,000 a year. Like you had to make less than $9,000 a year to qualify. Everybody go, it's not true. 12,000. Yeah, so you had to make like about $10,000 a year. We'll split the difference. So do you know how ridiculously high that bar is to meet? Like you have to be really, really poor to even qualify for routine Medicaid as an adult, right, or even a child in some cases. So what ended up happening is they had these categorical eligibility programs, right? So states have a lot of flexibility. So for example, if you, like South Carolina, where I've done a lot of research, they had the optional program for women and children, right? So if you were 185% of federal poverty level and you were pregnant, you could qualify for Medicaid as a pregnant mother through your pregnancy and for a certain period of time, and then your child was automatically enrolled in Medicaid for 2 years, right? Like that's a categorical program. So you're categorically eligible because you're pregnant. Family planning is another one, right? So a lot of states have a family planning program. Why would states want a family planning program in their Medicaid program? Yeah. When people have babies, they cost you money, right? So be very careful here. This is one of my areas of research, and I need to be very careful how I state this. You want families to have babies when they want to have babies, right? So you're not trying to like control the population by not allowing poor people to have babies. Like that is unethical, inhumane, and ridiculous. But what you don't want is for people who don't really want to have a child right now, but don't have the means to pay for contraceptives that would otherwise prevent those pregnancies. Like you don't want that barrier in place because that's not good for the kids, it's not good for the families, and it's not good for the Medicaid program, right? So those are like, categorical programs. But you can also be income eligible, right? So like, again, states, have flexibility for set those. So like Arkansas sticks in my mind because it was at 50% of the federal poverty level. Massachusetts is like 400% of the federal poverty level. So you can be up to 400% of the FPL and still qualify for Medicaid in Massachusetts. Now, it's like almost $60,000 a year, $70,000 a year, right? Why is there that much difference? Yeah. It's insane. Like that's the gist of it, right? So like $70,000 in Boston is going to look a lot more like 50%. Well, not exactly, but you see what I'm saying. I'll tell you this side note. So my wife qualified for the Boston Marathon this weekend, and so we're already like looking at places to stay in Boston. It's price gouging, and it's less than supply and demand. Anyway, like 500. The cheapest room I can find, like in Boston, is like $555 a night. So. Anyway, sorry. That was a shameless brag on my wife. I'm really proud of her because she, in 4 years, she's cut an hour off of her marathon time. And she's had, this was after 3 kids, right? So this was something that she just, So anyway, that's an 8:22. That's an 8:22 pace for 26.2 miles. Anyway, sorry. I got off track. Today was bragging. Please forgive me. I'm proud of her. All right. So anyway, the point is that there are different ways you can be eligible for Medicaid. ACA standardized that, right? And I'll talk about that next week. So they set it at 138% of the poverty level, right? So Arkansas, you're out of luck. You can't set it at 50. You've got to raise it to 138. With some caveats. So Medicaid. Medicaid, the financing of Medicaid is a little bit more tricky in some ways than Medicare. Medicaid is a federal-state partnership. So what that means is that the state is responsible for setting the criteria, administering the program. They get money from the federal government to do it, and they have to kick in state money as well. So there's a match, right? So there's federal money that comes to the state, there's state money that comes in, and then there's a federal match. So like the feds will usually match the state about 1-for-1. So as a state, you can say, we're gonna spend $50 million on healthcare within the Medicaid program. So if you match that 1 for 1, that's $50 million from the federal government, so combined, you got $100 million to work with to take care of your people. So some states, you know, if you are entrepreneurial to some degree and you really want to take care of your people, that's a pretty good deal because you can invest $1 and get $1 for your investment to help take care of this bigger group. Some states don't see it that way, but that's the way it works. So the problem is that state budgets are tough. And even though it is a investment, right, where if you invest some money in Medicaid, you'll get some federal reimbursement with it, states are going through some serious budget crunches, particularly with the recession. The recession hit states hard. And, you know, even trying to make the argument that you should outlay $5 million for family planning because you'll get $10 million, you know, you'll get another $5 million, so now you'll have $10 million. Like, those arguments are really hard to make when the state budget is in the red, right? Like, it's just hard to make. So whenever there's times of fiscal austerity, states have to make tough choices. And oftentimes, you know, and I hate to say it, I don't mean it in a disparaging way, but it's typically like, you know, a lot of the southern states, a lot of states that have a lot of demand and high need for those services are the ones that end up getting hit hardest with the recessions and the economic downturns, and those are the ones who often don't have very generous Medicaid plans in general. Some of it's practical, some of it is ideological. We're not going to dance around it. It's just the truth. But it is what it is. So this is a little run chart of federal funds that how funds run through Medicaid. So the only thing I want to point out is that even though Medicaid is a state-run program, over half of all the money that is invested in Medicaid in states comes from the federal government, right? So the federal government is still heavily invested in paying for Medicaid at the state level. So this is interesting, right? Sorry, I do research. This kind of stuff makes me happy. So this is Medicaid spending and enrollment, right? So you can see very clearly that they're affected by changes in economic conditions, right? So what happened in 2008? Yeah, really kind of leading up to 2008. So you see this gold line is enrollment growth, right? And this top line is spending. So, all right, obviously the key thing here is that as enrollment goes up, what happens to spending? Like, it goes up, right? Like, that's just kind of a no-brainer. But the problem is, you know, enrollment in Medicaid is particularly sensitive to economic downturns. You can see when the recession hit, enrollment goes up. What happened over here after 2010 when enrollment went back up? I'm throwing you a softball. What happened in 2010? ACA, right? So you see another, growth in enrollment there. What's interesting is, this is kind of an interesting side of what we saw happen with the recession in Medicaid. Who do you think was the largest demographic that grew within the Medicaid program during the recession? Kids, adults, or seniors? Adults? How many of you say adults? One of those ones where you have to raise your hand. How many of you say adults? How many of you say seniors? How many of you say kids? Yes, kids. Why? Why did you see such an enrollment in Medicaid during the recession? So the recession comes, people lose their jobs, right? Families lose insurance coverage when they lose their jobs. What happens? I don't have an income now, so my income threshold is much lower. The criteria for kids being enrolled in Medicaid is much more generous. So I don't want my kids to go without health care. I'll swallow my pride and enroll my kids in Medicaid. Adults. What do you think happened to the adults? Yeah, they're not going to enroll in Medicaid. Nope. So you saw that what happened with the recession is a lot of adults went without care, went without insurance, but they'll put their kids in Medicaid because that's a responsible thing to do as an adult, right? Like you don't want your kids to go without care. Anyway, just an interesting side note. Okay, this is one of those ones where I want your minds to just go like, what's going on here? So this is the percent of enrollment in Medicaid over here, and these are the percent distribution of the expenditures in Medicaid over there. So I want y'all to interpret this for me. If you look at Medicaid, I'm going to walk you through it or else it'll be chaos. If you look at Medicaid enrollment, which demographic is the most enrolled in Medicaid? Children. About half of all people enrolled in Medicaid are kids. What proportion of the expenditure do kids account for? 21. Adults, like your pregnant women, low-income adults, 27. So 1 out of 4, roughly, are adults. What proportion of spending do they account for?
15.
Elderly. Who are those people? So this are elderly folks who don't make any money because they don't have a job clearly and they don't have means of income. They qualify for Medicaid. I'll talk about this in a minute when we talk about dual eligibles. So these are dual eligibles, right? This is my grandmother. So my grandmother on my dad's side, my grandfather worked like, blue collar construction stuff his whole life, had a pension. Like they don't even do that anymore, but like, she drew his pension for years or whatever. They lived with my family. They moved in with us when I was a junior, senior in high school, right? So like I had to give up my room, and like they, had a hospital bed for my grandfather. My grandmother just like took care of him in the house or whatever. Anyway, he died, so my grandmother lived with our family. His pension wasn't much. We couldn't take care of her anymore. She started falling, and like she was having some problems. This is about 3 or 4 years ago, maybe 4 or 5 years ago now. I can get old. We just couldn't take care of her anymore. Like she needed to be in a nursing home. Like it wasn't safe for her. Like they lived with our family. Like that was, I'm a senior in high school. At that point, I was in my mid-30s, married with kids. Right, so you're talking about 15, at least 15 years. My grandmother lived with me. Right, like I was pretty attached to her, or lived with my family. So she was a dual eligible, right? So like we were sweating it because, like my dad's a preacher, right? Like preachers. They don't make any money, right? And there are a few of them that I'm not going to name any names, but like your old school preachers who like are really preachers, like they don't make any money. So I mean, my family is from, we have eager meat, like, we don't have a lot of money. You know how much nursing home costs? Nursing homes are expensive, right? Does Medicare pay for nursing homes? No. Who pays for nursing home care? Medicaid. Medicaid if you're what? Really poor, right? So my grandmother, like we were sweating it. It's like, are they going to count our family's income for her eligibility? Like we had to apply to Medicaid in West Virginia for her to get Medicaid so that we could get her into the nursing home, right? So when you go through that application process, if they count our family's income, she wouldn't have qualified because she was living with our family, right? So they do that sometimes. If you're living with the family, they're helping to pay for you, then we'll look at the family's income to decide. Fortunately, they just looked at her income, which was like a meager pension and nothing else. She qualified to be both Medicare and Medicaid. So Medicaid, West Virginia Medicaid, paid for her nursing home for, she was probably in there a year, I think, before she died. So those are the dual eligibles, and we can skip that slide in a minute. Like that's who the dual eligibles are, and those account for 20% of Medicaid spending, right? So that's a pretty big chunk. That's disproportionate to what they represent. Disabled, so people who have like legitimate disabilities that they qualify for Social Security, can't work for various reasons. Look at that. They account for 15% of Medicaid enrollment, and they account for about a little less than half of Medicaid spending. So when we talk about like Medicaid policy at the federal level, who's costing Medicaid money? It's not adults and kids, right? Like, I mean, they'll cost them a little bit of money, but, you know, the issue with Medicaid spending is what do you do about the dual eligibles and the disabled, right? So disabled, you know, this can be folks that have behavioral health problems, mental illness, schizophrenia, you know, things like that that require, you know, intensive inpatient therapy, things like that. Like, that's what a lot of this stuff is. So anyway, I just need y'all to understand that like adults and kids, 20, 30, 35% of Medicaid spending. For elderly and disabled, 65%. So when you're talking about like trying to curb in Medicaid spending, this is what you have to solve, not so much this, right? So drivers of Medicaid spending, acute care services, prescription drugs is a big deal. Enrollment growth is the biggest thing, right? Like as Medicaid growth enrolls, you're going to spend a lot more money. Dual eligibles are a big one. We talked about those. Those are low-income Medicare beneficiaries. There are about 10 million of them. They rely on Medicaid to cover premiums, cost sharing, nursing home, you know, things like that. But I mean, that's important. Like, you know, if my grandmother wouldn't have qualified for Medicaid, I don't know what we would have done. Like, it was not safe for her to be in the house, and there, I mean, we couldn't afford. I mean, I guess we just had to. I don't know what we would have done. I'll just say that it would have been not a good situation. And the reality is, there are a lot of families who find themselves in that situation. Right? Like, most of us have parents or grandparents that we're going to have to go through that with in some way, shape, form, or fashion. You know, those of us who kind of come from, you know, lower middle class backgrounds, like, that's going to be something that we have to contend with. A lot of state Medicaid. One of the big trends within Medicaid is a shift towards managed care. So, like, a lot of states have gone to a managed care model where they bring in private companies that enroll Medicaid beneficiaries into managed care plans, and we went through this in South Carolina a good bit. But the idea is that it's a way to control costs to some degree. I can tell you some stories about that. So here's some planning for you, right? So in South Carolina, they went to a mandatory Medicaid managed care enrollment. So you didn't have a choice. You had to opt out of managed care, right? So again, you got fee-for-service, which you can go to any provider, and they get paid a fee-for-service. Managed care, when you enroll with a managed care company, they get a per member per month premium, and they have to manage your care within that premium. So they brought in 5, 6 managed care companies. They each kind of had statewide coverage, but what ended up happening was that you had some managed care companies that targeted one part of the state, some that targeted another one. So, I kid you not, they put pregnant women into Medicaid managed care, okay? So they're on Medicaid 9 months when they're pregnant, 2 months when they have the baby, not even a year. So less than a year, they're covered by Medicaid. So they had to go through this automatic enrollment into managed care. In the middle of their pregnancy, right, randomly generated. So what ended up happening was that you have women who got automatically enrolled in managed care plans in the upstate that lived in the low country.
That was that.
Right? Like, I mean, theoretically, these companies had statewide coverage, but the reality was they had no provider contracts in the low country where they automatically enrolled them. Right? Like, you think that they would at least, it doesn't seem like it would be that hard, right? Like, at least put them in a managed care plan that's, you know, has an extensive network for where they live. Like, it was a mess. Like, I used to sit on these groups, and, like, it was a train wreck because, you know, providers weren't getting paid. Like, they were having, you know, pregnant women that they've been seeing the whole time show up at, like, month 7, and all of a sudden, they don't take their insurance anymore. They're not going to kick them out in the street. They're going to take care of them. But, like, it was a policy nightmare. But anyway, I can tell you funny stories about Medicaid managed care. I'll tell you one more because I think we're close to done. I think I got time for a funny story here. So I had a friend that I'm getting smart about this. That way I'm never like recorded saying stuff that, don't need to be recorded. So anyway, I had a friend, like I do a lot of health services research around Medicaid, health services, whatever. And a friend of mine runs one of the managed care companies that was in South Carolina. And he was asking me if I wanted to do a little bit of consulting because what was happening was that the state Medicaid program was withholding stuff like that. But anyway, I decided not to be a consultant because I felt like that was a conflict of interest because I do a lot of research on Medicaid. So, but anyway, I just gave you some friendly advice about how to profile practices and pull their data out and whatever. Anyway, pro bono. So expanding challenges for Medicaid. Expanding coverage under the ACA, that's the big challenge for Medicaid right now. We'll talk about that more next week. With the ACA and the expansion of Medicaid and the subsequent Supreme Court decision, like there's a lot of issues around that now. Ensuring that enrollees now have adequate access to care, right? So it kind of goes back to what I was talking about earlier when that you bring in managed care and you have these provider networks. A lot of times you have patients who are used to seeing providers end up not having contracts with people they're used to seeing. That can be an issue. There's still an issue. I'll show you a slide in a minute about access to care in rural communities, which is another area that I do a lot of work around. Another issue with Medicaid is trying to weather, actually I forgot I had a whole other set of stuff. Anyway, weathering the shifting economies and state budgets, right? Those are the big issues. I'm going to skip this. I don't think it was in the book necessarily. I already talked about this, but just the idea that everything is moving more towards capitated value-based pricing where they're paying fixed sums for outcomes now. There's been a big shift in that over time. Alright, this is what I need to get to. Some of the stuff is just like extra that I put in there in case we have time. So access to care, right? So Medicaid is important, private insurance is important. Does insurance always equal access to care? No, right, I kind of gave you the answer. So right now, as it stands, about 10% of the population under 65 doesn't have health insurance, right? Like that's down from about 17% prior to the ACA. 18 to 64, it's about 12%. Most kids, less than 5% of kids don't have health insurance. So most kids have health insurance. So that's where it stands now. I said this earlier. These dark blue states have uninsurance rates that are over 16%. Right. So the southern belts, southwest, rural, like kind of rural, rugged states, still have problems with insurance, right? Like it's still an issue. Tennessee and these middle blue states are kind of in the middle somewhere, and then you've obviously got your wealthier northeastern states that tend to do a lot better around these things. Anyway, a couple of key points here. When you look at the characteristics of people who don't have insurance, right? Like there are a few myths that we can put to rest very quickly. What's one thing that you hear about people who don't have insurance thrown around? Some of them are low income. What do you hear a lot?
They're not working.
They're not working. Low income, not working. What else?
Maybe illegal.
We just run in different circles. I hear those things too. One thing you hear a lot is that those are people who don't want to have insurance. Like those are people who can afford to have insurance, they just pay for health care out of their own pocket. Right? Like that's one of the arguments is the people who don't have insurance choose not to have insurance because they just want to pay for it themselves. Well, if you look at people who don't have insurance, that's less than 10%, right? So 9 out of every 10 people who don't have insurance are poor or near poor. Okay, so we can kind of put that to rest, right? Like these are not wealthy people who just pay for health care. Like that's not who these folks are. These are folks who are poor or near poor. Something about being connected to the workforce. I didn't throw that in here, but I talk about it in another class. what proportion of people who don't have insurance do you think are connected to the workforce, either full-time or part-time?
What is it?
Me, we did this yesterday.
Yeah, it's about 75-80%, right? Like most people who don't have insurance are actually connected to the workforce, meaning they actually work part-time or full-time. So think about that. These are poor folks who work, right? It's the working poor, right? So that's part of the argument philosophically around why it's important to try and extend coverage to these folks. I mean, these are not, a lot of the really poor and the really sick and the really downtrodden, like they're already covered with Medicaid. The people who don't have insurance now, these folks who are working hard, connected to the workforce, are making an effort, it's just not affordable. Like they don't make enough money to pay for it. So like that's an issue. And it matters. Like it matters a lot. So this is just some data on children, right? So if you look at well child visits, kids who don't have insurance are far less likely to have well child visits, much less likely to have a usual source of care. If you look at adults, same thing. Like they're much less likely to have a usual source of care, much less likely to go to the doctor, and they're definitely not going to get into a specialist, right? Like you can forget that. They're much more likely to die. So if you look at uninsured versus private, and if you look at hospital mortality, they're more likely to die. Why? Not because they're treated differently, it's because they're a heck of a lot sicker when they get there because they don't get a lot of these other preventive health measures like, interventions leading up to it that make it much more difficult to take care of them in the future. Cancer is a big one, right? So the likelihood of being diagnosed with late-stage cancer, insured versus private, right? So this line is if they're equal. So they're twice as likely across the board to be diagnosed with cancer as much later in the process, which means what? Yeah, their treatment options are limited. They're more likely to die from that, right? So here's the so what. We're almost done, I promise. You guys have been great. Here's the so what with insurance. So there was a study done in Massachusetts. Benjamin Summers and Dr. Long, Sherry Long. So Massachusetts passed healthcare reform in mid-2000s. It's basically the template for the ACA, right? And I don't want to go into the details, but I mean, it's almost the exact same thing as the ACA, just within a state. They did some really nifty research and looked at mortality over time before and after the implementation of the Massachusetts healthcare reform. Okay, so what they found was a 2.9% reduction in mortality after that reform went into place, right? So they reduced the level of uninsurance significantly. Folks had much better access to care, much more affordable. It wasn't perfect, but it definitely had an impact on insurance. So when they did the math, right, when you look at that and you calculate it out, for every 830 people who gained health insurance, that equates to one death. So for every 830 people who didn't have insurance before that do now, you prevent one death. Okay. Now I know that as graduate students you know a little bit about research, but I can tell you as a researcher the study that they did, like it was top shelf, right? Like it was legitimate, like propensity matched. They looked at the counties in Massachusetts and matched them with counties across the country that are almost identical demographically, same characteristics, like statistically balanced, like across the board. It was solid, right? If you do the back of the envelope calculation, you look at how many people gained insurance under the ACA. That's a theoretical 20,000 deaths that are prevented by folks getting access to insurance under the ACA. Right? Like these studies will happen. We haven't had enough time to see that type of impact. But if you just, if you take the numbers from the Massachusetts study and you extrapolate them out nationally, insurance matters, right? Like it's important. Insurance, I had a guy argue with me one time that I've never seen insurance, not having insurance as a cause of death on a death certificate. And I'm like, that's because you're an idiot, right? Like, you don't see obesity as a cause of death on your death certificate either, but it's clearly a contributing factor. So people get really squirrely when you try and talk about people dying because they don't have health insurance. But the fact of the matter is they do. And until we can kind of come to grips with that, we just got to come to grips with it. The insurance matters. It's important. And if you want to improve health and well-being, and if you want to save lives, people have to be able to get into the healthcare system, right? And they get into the healthcare system by having health insurance, like it's important. Now, I will say I was invited a couple years ago to talk on a panel with the author of this paper. I was invited from the public health side to talk about how you communicate research with policymakers, and she was invited on the healthcare side about how you communicate with policymakers. So anyway, it was one of those moments where I felt like I had arrived in the research world, right? Like you're sitting there with, this study won the Academy Health Services Research Award, by the way, so it's like a big deal. So anyway, I got to hang out and like talk on the same panel with these folks. Anyway, so anyway, it matters. So dimensions of access, we're almost done, I promise. Availability, right? So services have to be available. That's not always the case. It could be because clinics aren't open. It could be because they're too far away. It could be because you don't have transportation. All that matters. Accessibility, right? Clinic hours. I mean, there are a host of factors that can kind of contribute to this, right? It's like I work a lot with public health departments, and like, you know, that's one of the complaints you get a lot from them is that, like, you know, people can't get to the health department when they actually can get to the health department. Like, they're open during working hours and people have to work. Therefore, the people who need to go there can't go there because they're working, right? So just because you have structure there doesn't always mean that you have access. Acceptability, right? So like alignment of culture. So we try and superimpose our own perception of what's important and what services people need and how they need to get that with what it needs to be. And sometimes we don't really respect different cultures and different needs of individuals who are seeking those services. So there has to be some alignment, of acceptability from a cultural perspective as well, and affordability, right? Like who's paying for it and the ability for individuals to pay. That's a big deal. I mean, you can have perfectly good access in a community, but it's just so cost prohibitive to a lot of folks that it's not really affordable. So affordability really kind of undermines this idea of access. And another issue about access. This is a map of every county in the U.S. There are like 3,100 counties in the U.S. These are primary care health professional shortage areas. What is that?
Providers.
So these are counties that statistically do not have enough primary care providers to take care of the number of people who live in that county. So all these blue counties are shortage areas. So even if you have insurance, chances are, if you live in one of those counties, you're going to have a more difficult time finding a primary care physician than if you live in some of these other counties, right? And these tend to be concentrated in where? Rural communities, Midwest, Southeast, right? So even when you do have insurance, that doesn't always mean you have access to the services and the providers that you need. So here's my summary. This is very scientific. It's a complex mess, right? Like we're just scratching the surface here. It's a complex mess, but what you should be happy about is you're going to have a job because it's a complex mess and somebody has to figure it out and somebody has to manage it. And that's what's going to give you all jobs when you get out of here. So that is where I'll leave you. And I'll say, you got 1 minute or 2 minutes. So again, that kind of gives us a summary of healthcare costs, the structure of the healthcare system, how it's financed, where the money goes, privately and publicly. So next week we're going to talk about the ACA, and this will kind of help frame up what we're going to talk about under the ACA. So that's where we'll be next week. So you guys have been great. I really enjoyed it. Thanks for hanging in there with me and laughing at my dumb jokes.
Thank you. The best part so far. You're really
Talking.